Good afternoon, everyone. My name is Susan Lynn Osterly. I'm the VBID Health Administrator. I'm pleased to welcome everyone to the ninth convening of the Low Value Care Task Force. I'd like to take just a couple of minutes to go over some logistics. We'd like this meeting to be as interactive as possible. So when you'd like to ask a question and or make a comment, please use the raise hand function. There's directions right here. Please click this hand button. Cliff will do his best to call on members in the order that hands are raised. When it's your turn to speak, please remember to unmute yourself. We're also asking everyone to keep their cameras off unless they're speaking, but when you do speak, even just to make a comment, we'd love for you to unmute yourself and turn your camera on. We have approximately 50 people that will be joining this meeting, and so that's a lot of little Brady Bunch squares on your screen, which is why we're asking most people to keep their cameras off unless they're speaking. After you're done speaking or making your comment, asking your question, please lower your hand. And now I am very pleased to introduce our esteemed moderator, Cliff Goodman.
Thank you very much, Susan Lynn. Great to be here. Great to have everyone here as well. We have a packed agenda that's going to go until 4 p.m. Eastern. There's some very kind of special pieces to the agenda. You'll be hearing about that soon. What we'd like to do, though, first is acknowledge all the folks who are on. I know that not all of the folks can join for the entire time until 4 p.m. Eastern, but I wanted to ask everyone, and I'll probably go in alphabetical order, starting with our members, to simply do the following. I'll call your name. Give us your name and affiliation, and that's it, except if you are new to this. If this is the first time you or your organization have attended one of these Low Value Care Task Force meetings, in addition to your name and affiliation, tell us in a sentence or two what brought you here. What makes you find yourself on this call for low value care? So name and affiliation only if you've been here before, for the first time, a sentence or two about what brings you to this meeting. And we're going to go through a list of members first, we'll then hit our speakers from whom you'll hear later, and then other attendees as well. I'm trying to get everybody to the extent that I can. Let's start, actually, Hassan Azar, you are listed alphabetically at the top of the members, and you're new. So if you are there, Hassan, don't know if he's here yet. Don't see him yet. Okay. Alina Baquette Simpson. Is she on yet? Don't see. Not yet. Okay. Beth Bodant Seiler.
Good afternoon now. Great to be here. I'm with Altarum and the Research Consortium for Healthcare Value Assessment with Mark.
Great, thank you. Thank you. Is Muna on? Muna Banji? Not yet. Beth Bortz. Beth?
Hello, Beth Bortz with the Virginia Center for Health Innovation.
Thank you very much. Gwen Darian.
Good morning, Gwen, or good afternoon, Gwen Darian with Patient Advocate Foundation and National Patient Advocate Foundation.
Good to have you once again, Gwen, thank you. And Josh Fangmar.
Hello, this is Josh Fangmar, Research Director for Minnesota Management and Budget State Employee Group Insurance Program.
Great, thank you, Josh. Nancy Junto.
Morning, everyone. Nancy Junto, Washington Health Alliance.
Good to have you. Carol Huffman.
Hey, good morning or afternoon, and I'm from Emblem Health.
Thank you, Carol. Chris Jude. Chris?
Hey there, Chris Jude with CERN Health.
Great to have you back so many times, Chris. Thank you. Robin Kahn.
Robin Kahn with Willis Towers Watson.
Great. John Keats, is John on yet?
Yes, I am. Hello, Cliff. John Keats from Cigna. Glad to be here.
Glad to have you, John. Ira Klein. And he'll be maybe coming on.
No, I'm here. Sorry, I couldn't get off mute. Ira Klein here from Health New England, former J&J, former Aetna, former God knows what.
Well, all those formers add up to our being glad that you are joining us yet again, Ira. Thank you. Beth Koester.
Hi, it's Beth Kester. Glad to meet you. I'm from Harvard Pilgrim Healthcare.
Thank you, Beth Kester. Glad to have you. Cheryl Larson. Cheryl?
Hi, Cheryl Larson, Midwest Business Group on Health.
Great. Thank you for rejoining. Jeff Licenze.
Yeah, Jeff Lassane. I'm here from Anthem.
Thank you, Jeff Lassane. Next up is Claire Levitt.
Hi, everybody. Claire Levitt from the city of New York.
Great. Carol Mendoza.
Hi, good afternoon. Carol Mendoza, most recently Health Benefit Strategy Leader at IBM and currently MPH candidate at GW.
Great. This is reminding me what a great sort of distribution of representation we have at these meetings. I love it. David Merkin. David?
Dave Merkin with Millman MedInsight.
Thank you, Dave. Great to see you yet again. Is Joe Miro on yet? Not yet, perhaps. Jason Parrott. Troy Ross. Perhaps not yet. Is John Rother on? Is John Rother on yet? Okay. Wendy Shanann Richards. Wendy from Aetna. Don't see her. And Mike Sherman from Mike Sherman.
Hey, it's Rich Petrucci. I'm covering for Mike Sherman today from Harvard Pilgrim Tufts.
Oh, good. Thanks, Rich. Good to know. Thank you.
You're welcome.
Scott Spradlin. And Karen, I know Karen Von Colliel, you're here?
I am. It's Karen Van Colliel with the Florida Alliance for Healthcare Value.
Thank you, Karen Von Colliel. Very good. Lauren Bella?
Hi, Lauren Bella here. Good to see you guys. Walmart, but historically a part of this group with the Pacific Business Group on Health. Good to be here.
Right. Thank you. Great, Lauren. And Mark Weinstein. Mark will probably come. He comes quite often. So with regard to our speakers, just to let you know, I think we've already heard from Beth Bortz. Mike Chernow, you need to say hi.
Yes, I do. Hello, everybody. I am thrilled to see you all. Cannot wait for the day to progress and look forward to closing it out at the end. Thanks, Cliff.
Thanks, Mike. Carrie, Kala?
Hi, everyone. Carrie Kala, professor at Dartmouth and low value care researcher. I'll be presenting later today at 2 o'clock. And thank you so much for having me.
Thank you for joining us, Carrie. Karen Johnson.
Hi, with the Washington Health Alliance, and I get to present to you on a really great project that we're doing with Mark as our advisor.
Definitely looking forward to that, Karen. Thank you. Brian Kean. We've got, I think, Brian and Kathy McKeon, both from Merck, I believe.
Cliff, thank you. It's Kathy McKeon. Appreciate and excited to be here. So myself and Brian will be joining later to talk to you about our value-based insurance design and oncology. So thank you.
Excellent. Later in the afternoon. Thank you very much, Kathy. Carlos Arance.
Everyone, I'm Carlos Arance. I'm a second-year fellow in the VA UCLA National Clinician Scholars Program, and I'll be presenting a little bit later today on measuring grade D services in medicine.
Excellent. Thank you. I want to acknowledge our sponsors here. Several are here, I believe. I don't know, is Sharif Abdullahi here yet from Merck?
Yep, so Sharif here. Hello, everyone.
Thank you, Sharif.
Affordability and sustainable access solutions for Merck globally.
Glad to have you, Sharif. Thank you. Brian Agnew.
Hi, this is Brian Agnew. I lead U.S. and Canada Policy Advisor.
Thank you. Glad to have Pfizer represented. Emily Ahrens from Sanofi. I don't know if she's joined yet. We have also from Merck, Gurjan from Merck.
Hi, this is John from Affordability Solutions and Sustainable Access team from Merck. Thank you.
Thank you very much, John. Sammy Doherty.
Hey, this is Al Lapidus. I am filling in for Sammy and will be going forward from Pharma.
Okay, good. Glad to have Pharma here. Thank you. Next is Michael Pass. Mike?
Good afternoon, everybody. This is Michael Paz. I'm with AbbVie Value and Access Medical Affairs.
Thank you, Michael Paz. Very good. Jason Spangler. Jason will be coming shortly, I think. He makes most of these meetings. And next is Rocco Zullo.
Hi, everyone. Rocco Zullo, Health Policy Liaison with Medical Affairs at GSK.
Great. Okay, one more set of folks to go through here. Thank you all. There are some others in attendance here. I want to grab as many of those as we can. Michael Boudros, are you there, sir?
I am here. This is Michael Boudros. I have a lot of hats related to this organization, but I could say today I'm here on behalf of the Smarter Healthcare Coalition, which is doing work on low value care policy.
And you happen to be very familiar with this program, Michael, as we know.
Yes.
Thank you. New is Amber Burkhart. Amber? She's there, yeah.
Yeah, hi, good afternoon. My name is Amber Burkhart. I'm the new manager for the low value care portfolio at Arnold Ventures. So I look forward to working with you all. Thank you so much for the invitation.
So Arnold Ventures does have a portfolio in this area, rather new one, correct?
Yes, correct. And we're building it out at the moment, but we do have a few grants we're funding in low value care, and we hope to grow that portfolio.
You are in the right place. Thank you for joining.
Thank you for
Jason
the invite.
Buxbaum. Thank you, Jason Buxbaum, who's also quite familiar with the program. Okay. Let's see. I think Marcos Daiquiri, another representative from Millman. Don't know if he's on yet.
Thank you very much. And A+ for reading a list. But Marcos Thackeray from Millman, pleasure to be here, everyone.
Excellent, thank you. Richard Dalcole.
So I'm playing the part of Richard Dalcole today. It's Carol.
Oh, okay.
Thank you.
And Carol, remind us why you and or Richard would be here.
Oh, we love you guys. We would never miss an event with Michael and Mark. No, Dr. Dalcole is our CMO, and we are working on at Emblem Health, and we are working on several different projects relating to low value care. And so we're always happy to participate. Karen Ignani was at the seminar that you guys had recently. And so I'll just say if anybody, I know a lot of people are inspired by her talk, and if anybody has any follow-ups that they'd like to talk to us about, I'm available after any of these sessions.
Excellent. Thank you. And by the way, I saw that Michael Sherman joined. Michael, we're just asking people to give a name and affiliation if you've been here before, and if not, something new. Michael?
Yeah, sorry, it's one of those days, I'm sure people understand, but my colleague and Senior Medical Director, Rich Petrucci, is here. So Michael Sherman from Harvard Pilgrim Healthcare, and following our coming together with a competitor of Harvard Pilgrim Healthcare and Tufts Health Plan, since we haven't introduced a new name yet. And I have been here before, and I really am so appreciative of the important work that Cliff and the Lewin Group are doing, and Michael and others. And really, this is just such a critical topic for us.
Thanks, Michael. And Cliff is just the moderator. It's Mark, Mike, and many others are doing the real work.
Yes, Mark, I don't want to leave that Mark Fendrick, of course, who's really been an industry leader here. So again, a reason not to mention names, or you start leaving people out.
All right, good, thank you. I see Dan Gorenstein. Not yet. Francesca Hammerstrom.
Hi, yes, Francesca Hammerstrom with Milliman MedInsight.
And so we know that Milliman has been here before. We're glad to have you with us. Lloyd Kapp.
Yes, my name is Lloyd Kapp, and I'm with Blue Cross Blue Shield of South Carolina. I'm one of the medical directors there, and I am filling in for Michelle Davis, and along with Wanda, and we have a group that's part of our event where we are looking to help reduce low value care within our network here in South Carolina.
Excellent. You two are in the right place. Thank you very
Thank you
much,
very much.
Lori. Okay, Alexander LeBerge. Not sure.
Sorry, Alex LeBerge. I'm from Centers of Medicare and Medicaid Services. Just keeping abreast of these important initiatives for our models.
Thank you, Alex. And we're keeping abreast of developments at CMS as well. Thank you for being here. Next up is Allison Lapidus from Pharma. I think Pharma is already well represented. Michael Maddalena.
I'm Mike Maddalena. I'm an independent consultant. I work with some large plan sponsors who are interested in using, applying these techniques of identifying low value care and eliminating and reducing. Thank you for having me.
Thank you, Mike Maddalena. Great to have you. And over to John Morgan. John may be joining us soon. Anikia Nelson. We have great representation from Millman. Anikia?
Yes,
you there?
good afternoon. Good afternoon, everyone. Anikia Nelson. I'm a physician and product manager for the Health Waste Calculator at MedInsight Milliman.
Excellent. Milliman is, as I said, very well represented. Richard Petrucci. Richard, also from Pilgrim.
Yeah, hi. I already introduced myself, Rich Petrucci.
Oh, yes, that's right. Thanks. Got it. Did get you. Kyle Russell.
Hi, everyone. Kyle Russell, Director of Strategy and Analytics at Virginia Health Information. And we provide data and other support to the Virginia Center for Health Innovation and their low value care work in the Commonwealth that Beth Bortz will speak about later today.
Thank you. I don't know if my former colleague Corinna Sorensen is on. Corinna, are you on? Maybe not yet. Katie Spangler.
Hi, everyone. Katie Spangler with Spangler Strategies and also co-director of the Smarter Healthcare Coalition.
Excellent. And have I called out Scott Weingarten yet?
Hi, it's Scott Weingarten. I'm from Cedars-Sinai, Stanson Premier. Good to be here.
Great, thank you. And I think, and Tawanda Wilson has already introduced herself. We've got that, got her. So that is a very good turnout. Good gosh. I know that some people will be joining in a little while as well. With regard to whom you just heard, this low value care task force, we're now in our, I guess, 9th convening. One of the more impressive things about it among many, not only have we gotten things done and spread a word with data and good case examples and so forth, but as I think folks can see, and maybe Mark will kind of weigh in on this as well in just a moment, is that the kinds of stakeholders represented here, it's a breadth and a depth that comes to this issue. And every time we reconvene, we have new folks bringing not only greater depth, but a wider set of these representative stakeholders, all of whom are needed to make this thing work. And just as a setup for later on today, and Mark's going to go through the agenda, I know, you're going to hear some speakers that are going to talk about some sort of sentinel developments affecting low value care and how we do our best to manage it. And then toward the end of the day, we're going to hear some member updates. That'll be very exciting. And then a kind of a special edition session for Mike Chernow, but I'll let Mark Fendrick tell you about that in just a moment. So first, before I hand it to Mark, thank you all for being here. Thanks for the introductions. Good to hear about the newcomers insofar as what brings them here. Over to Mark Fendrick. Mark?
Cliff, thank you very much. We're off to a tremendous start, and I'm never going to try to ever claim to be a moderator to your esteemed level, but I am going to just see if some folks who might have logged on after you went through their list are here. Is Silas Martin on the line?
Yes, hi Mark. Silas Martin from Johnson & Johnson. Thanks for having me.
Thank you. Thrilled to have your one-shot vaccine here in Michigan and no cost sharing because of value-based insurance design. So great to have you. Mark Freeberg, did you join after the roll call?
Yes, hi, Mark Friedberg, Blue Cross Blue Shield of Massachusetts. Nice to be here.
Always to have you here. How about our colleague Suzanne Goot? Are you on the line?
I am. Good morning, everyone. Suzanne Goot with AbbVie Market Access Team, National Employer Team.
As you know, we have many exciting launches in the immunology portfolio here in 2021, but it's not going to end in 2021, and we anticipate.
There we go. And Adam Beck.
Adam Beck.
A low value care task force pioneer. Are you with us?
Hi, Mark. Adam Beck with America's Health Insurance Plans, soon to be only AHIP.
Great. Great to see you, and thanks to all of you, everyone, for this. So I promised the speakers that, which is rare for me, I'm going to behave as if I'm a value-based provider and go with a global budget as opposed to my usual fee-for-service approach and taking all the time that Cliff and Susan Lynn and Jordan allotted to me. So I want to thank the folks from VBID Health, Jordan Clark and Susan Lynn Osterly, for pulling this all together. And I want to thank the sponsors that have all been identified thus far. When Mike Chernew came up with this idea, the task force, as Cliff said, this is our 9th convening, we were pretty skeptical about where this thing would go. And as you know, we go basically from meeting to meeting, largely driven by the members' interest. And when people ask about the task force and how it's going, I tend to tell folks, and you all know, that I want to be remembered more as the person who made high value services more accessible and affordable so we could enhance equity and reduce disparities. But Mike and the VBID Center board pushed me relentlessly to become a low value care person, which I was chagrined to become. And Carol Hoffman and others raised the VBID Summit, where we talk more about reducing barriers. It's really hard to get people to come to talk about spending more money to make Americans healthier. But what Mike and I have seen from the beginning of his vision of this task force, that when you talk about the potential of lowering aggregate medical expenditures and potentially making people healthier, the momentum and the interest has been remarkable. And for the most part, we feel very lucky to have all of you representing key stakeholders in this dialogue, but we turn a lot of people away from this discussion so we could kind of stay on task, and Cliff keeps us online. And it's been really rewarding to see that when Mike and I, with the help of our team, Jason Bucksbaum and Michael Boudros and Katie and others, came up with this identify, measure, report, and reduce low value services. We never really thought how quickly we'd be able to make significant progress, particularly around identification and measurement, as well as reporting of low value care. So as we head into this new year in the post-COVID world, Susan Lynn, if you could, or Jordan, if you could just advance to the agenda. I think that you'll see today's session is pretty much a hybrid around our activities in this space. Identification pretty much done in our first 2 meetings, and there's a handful of you. I see, Cheryl Larson and Brian Agnew and many others who were there at day 1 where we picked our top 5. And we've gone on to identification, to measurement and reporting. But today, largely on Mike's push, we're going to try to get into that very uncharted and most important territory to actually be able to show various stakeholders, policymakers, payers, and providers that we are able to use a scalpel and not a sledgehammer by reducing and deterring the use of care that's not making Americans any healthier. And I just, as you see in the amazing newsletters that I hope all of you get, that we had planned in our strategic plan to send out 2 times a year, now Jordan is scrambling to put 8, 9, 10 specific items about low value care in newsletters that seem to be going out every month, if not more than once a month, kind of suggesting that it's not just our task force, of course, but there has been fire kind of growing around this idea that the way to be able to provide better access to those services that we know improve health, one way is to pay for them by no longer paying for that. So you know, some of you might recall that that term that Brian Agnew came up with, identify and reduce low value care to create headroom to be able to provide increased and better coverage for high value services, has actually started to take a life of its own. And as Representative Cliff said, by the type of payers on this call, from employers to states to CMS to New York City to large coalitions in Chicago and Florida, and I believe Troy Ross has joined us in the Midwest. It's extremely exciting to me. So the agenda is in front of you. We have a really interesting and exciting report from the Washington Health Alliance on a very specific multi-stakeholder project that Karen Johnson will fill us in on, supported by Arnold Ventures and others. Our colleagues from UCLA have already presented to the task force on various measurements of low value care in commercial and private payers. Carlos Arance will provide some really interesting information as we've been asked to quantify the use and cost of U.S. Preventive Services Task Force D-rated services in Medicare. And we'll ask our colleague Katie Spangler to jump in during that segment to fill in the task force on specific policy efforts in the new administration to bring more attention to the hundreds of billions of dollars that could potentially save by Medicare if they would get serious about non-coverage for these D-rated services. And then we're thrilled to have Carrie Cola from Dartmouth, who has been alongside us and maybe even before us in thinking about low value care, and has published numerous Sentinel articles, including a very nice piece with her colleagues in American Journal of Managed Care, which is titled something like Imagine a World with Low Value Care. And Carrie, you could tell me what appropriate music should accompany that, that very upbeat vision that we know is very hard to achieve. We'll have a break when Carrie's done, somewhere around 2:30, and then we'll basically turn it over to the members that have volunteered to give us updates on activities in their own organizations. Depending on how that time goes, we may have a little time for others who want to chime in with 1-minute blurbs about things they might be working on. But after that, we are going to do something that we haven't really done before, is kind of see if we could hear from you about your appetite about getting serious about having payers be more accountable and proactive about reducing low value care. And Mike knows I always like to talk about these general non-specific ideas, and he's been very kind as he's pushed me over the 25 plus years I've known him to do concrete actions, and he'll be asking you to do the same. So I am really happy, Cliff, because I know you told me the agenda is going to be packed, and we know that members often have lots of things they want to say, to turn at least 25 minutes back over to you so we could get the session started and allow ample time for discussion, perhaps not only about the specific presentations from Karen and Carlos, but also allow some more general conversation from the group in the time that I'm giving you back. Sound good to you?
Great. Usually we are politely waiting for Mark to make his final comments, which are always stellar. And this time you hit on them early. And so that's wonderful. I just want to add, insofar as a broader context, to back up what Mark has been saying and being pushed by Mike, and that is this group has led the way, making certain forms of progress. Just the idea of low value care in the first place and defining it, the top 5, the first 5 that we derived through a consensus driven process and so forth. Progress has been made, but we and others are getting impatient for the next leap here. And that is part of kind of our sort of parallel focus, if you will, of today's meeting, is like, how do we take the very next big step? Politically, there have been some changes, some shifts, basically some tectonic shifts in our political and economic environment. A lot more attention on certain people being left out of the healthcare system that need to be brought back in. A lot of attention on how we're going to pay for expanded healthcare. And so, again, we're looking at low value care as a way to become a much more efficient and equitable, support a more equitable healthcare system. So that's kind of sort of adding a little bit a spice to why we need to be here today. So to kick us off on that, and Karen, we're going to get a little more time if you need it than we had planned. Very glad to introduce Karen Johnson from the Washington Health Alliance Driving Value Project. Karen is the Director of Performance Improvement and Innovation. Karen, we originally were going to set you up with 15 to present and 15 for discussion. If you need a couple more than 15 for your presentation, that would be fine. Not a lot more, but there's a little bit more wiggle room there for you should you need it. Over to you, Karen Johnson.
Thank you. I'm going to get my everything going here. Hello, everybody, and thank you. It's good morning here, good afternoon, wherever you are. And thank you for the time, because there's a lot of enthusiasm that we have for this project, and I really appreciate the opportunity to share it with you. I think we do represent that sort of boots on the ground perspective of how do you make this work in real life. And for me, you know, that next big step, this really represents that for me personally, because I spent much of my career working as a benefit consultant advisor, most of that in the Kansas City market. Hi, Troy Ross out there. And for me to be able to now do this work at scale in an organization like the Washington Health Alliance is really sort of that next step. And I will just say that 20 years ago, 25 years ago, I was reading about Mark Fendrick and all of the great work he was doing in VBID. So to get to work with him on this project as an advisor is really extraordinary. And so grateful for that. And also grateful for the support of Arnold Ventures. And hello, Amber. We were just introduced to Amber this morning via email by the Arnold team that we are working with. We are part of their portfolio in low value care, and they've been great collaborators with us. And so I'm here to tell you what we have affectionately referred to as the Driving Value Project. The primary aim of this project is to use data to inform and engage purchasers in both individual and collective efforts to improve the value of care for their plan participants. We are just now wrapping the first phase of this project, which is really the collective impact piece of this, which we started in late summer 2020. What I will share in the next 10 to 15 minutes is a flyover of the work that is an attempt to leverage the VBID concepts and a collective impact model. So sort of a mashup of two great concepts and ideas. It is led by our purchasers, but it also engages providers and health plans in the efforts to improve value. And I'll describe where we are today, which is really settled on working on improving the care for low back pain together, how we got here, and a little bit about what we learned along the way. And we'll look forward to hearing your insights and feedback as well. So for those of you who aren't familiar with this, just very quickly, who we are at the Washington Health Alliance is a member-based organization. You see the breadth and strength of our members represented here on the side. This is just a small sampling of our more than 185 members that represent purchasers, health plans, providers, and other important healthcare stakeholders across the state of Washington. The vision that all of these members share is that Washington state will be in the top 10% of the nation in the delivery of quality evidence-based care. And we are particularly grateful to the purchasers who participated in this project with us. They represented a nice cross-section of public, private, and union trust perspectives and more than 500,000 covered lives in Washington state. So the project that I'm going to talk to you about today is essentially a microcosm of what we do at the Alliance. We act as a trusted convener. We provide transparent reporting on healthcare cost and quality, and we are always striving to drive the work to action. And as most of you know, none of this is easy, but driving to action is certainly the most challenging. And while we believe we've gained some great insights along the way, we're, again, eager to hear your feedback and insights as well. So the Washington Health Alliance has been on the journey to improve value for quite some time. I've now been with them just a little over a year, and it's been a fantastic year, but the work of the organization itself dates back to 2008 when the first community checkup was published, which is reports on cost and quality of care in the state of Washington. I think one of the things that really sets the Alliance apart is the transparency with which we report. So since the first community checkup in 2008, the Alliance has been publicly reporting on care quality at the medical group level and the clinic level, actually. Our member committees, particularly the Quality Improvement Committee, which is made up of senior clinical leaders from across our organizational members, they really sort of vet the methodologies, work with us, we work hand in glove with them, and they're behind all of the public reporting that we do at the Alliance, where we just recently released the 15th community checkup. In 2014, we were one of the first to publish on choosing wisely measures. We launched the first Do No Harm reporting series in 2018. This is built on the Milliman MedInsight Health Waste Calculator. We published 2 reports that year. We did some specific work with the Boeing company around their ACOs and helping them identify low value care within those agreements. We also supported an ad hoc work group on Drop the Pre-op. In our most recent First Do No Harm report in 2019, we also reported on that publicly at the medical group level, really at the behest of those medical groups on which we were reporting, which says a lot, I think, about our members and the strength of their commitment to this. And that brings us to where we are today with the Driving Value Project. So the first order of business in this project was to develop customized reports for our purchasers participating in this project with us to use the data to identify the opportunities. And we wanted to reflect both low and high value improvement opportunities. I'll talk a little bit about how we did that. But the data that we use is the Washington Health Alliance data set. It represents about 4 million, a little over 4 million commercial and Medicaid lives in the state. All of that data is submitted voluntarily by health plans and self-funded purchasers across the state. So we used a really it's what we do all of our reporting from, and it's a well-established and trusted data set in the state. We applied a couple of well-established analytic tools to that, the Milliman MedInsight Health Waste Calculator, of course, to identify the low-value improvement opportunities. And then we used a subset of our community checkup measures to report on what we saw as some high-value improvement opportunities as well. And so not going to dig into the data, but suffice it to say that we found some interesting things. Each of the purchasers got really rich reports. We see in the graph that we have shown you here the low value care services per thousand, with the burgundy line at the top representing our 8 purchasers, the average of them, and then the light blue line indicating our Washington state commercial average. And of course, you know, as we, I think, have seen in many ways, there are some encouraging indicators that the rate of low value services is going down. I will say that the purchasers took note that they were running a little hotter in low value care than the Washington state average. I think we had some very rich benefit designs represented across those 8 purchasers. We'll be interested to dig into that when we get into the more technical assistance, individualized work with each of those purchasers. But I think what we also found is something that's not surprising at all to this group, that the most prevalent low value care services are really deeply entrenched. And in fact, when we looked at this across the board, we could say no matter how you look at it, the top 10 is the top 10. I think you've already gotten to the top 5. But it was interesting as we looked at this top 10 and looked back at the first report we published in 2018, they were all the same except for one measure. And so you see indicated there with that top 10 in parentheses, the ranking of that particular measure or service in the first report that we published. And the only one to not be included in this top 10 is a measure that was not included in the current version of the Health Waste Calculator that we applied. As you see, this represents 92% of all of the services that we were identified as low value in this particular round of analysis. And if you look across the purchasers, all but one measure for one employer were the same top 10 across all 8 purchasers. And so, you know, there was a lot of ability to look really closely. And one of the things that stood out for us in the collective discussions that we were having with our purchaser around this was that opiates for acute low back pain continues to be a persistent measure, regardless of how you look at this. So when it came to coming together and choosing what to work on as a group of purchasers, they wanted it to be actionable, doable, and meaningful. They wanted it to be actionable for all, that there would be a role for everyone. They wanted it to be doable in the sense that they didn't really want to fight philosophy of care issues. They wanted to do this around something where the evidence was clear but poorly implemented, and low back pain is probably a poster child for that, and something where there was meaningful impact. They wanted to really do something that was important to them, that they thought mattered, and that would also have a meaningful impact on the care and lives of the folks that they support through their plans. So low back pain, as I said, hit it on all fronts. And the goals that they set about were to increase the reliance on evidence-based, non-opioid, non-surgical care. Non-invasive was probably the term we landed on closer to the end of this, reducing inappropriate opioid prescribing and avoiding unnecessary surgery. And so I wanted to share some of the learnings along the way. And so, you know, I think transparent reporting, a hallmark of what we do, and so many in this room are going to talk about, you know, it's so useful for identifying the problem, but rarely do those same reports tell you what to do about it. And so to inform and motivate action, you really have to understand and apply the evidence. So it sounds a little obvious when I say it out loud, especially in a room like this where we are all about the evidence. But I think there's an important and here. And I think that and is that while employers are emphatic that they want evidence-based care for their plan participants, the typical benefits purchaser is hard pressed to tell you what that looks like for any given condition. And I would argue that nor should they have to. You know, having served as a benefits consultant, as I said, for more than 20 years of my career, I can assure you that most typical benefits brokers and consultants that act as the trusted advisors to these purchasers are no more adept at this than the purchasers are. So I think it's a gap. I think it's a really important gap that we need to think about and fill in some kind of a meaningful way. And what I'm going to talk to you about for the balance of the time is how we set about then to become sort of the evidence translators for our purchasers in a way that they could wrap their minds around it in a value-based sort of insurance design framework. So I won't talk to you a lot about the evidence. I'm sure you all are, there's probably folks in the room much more expert on this than we are, but I do want to highlight that as we took on this role of being the evidence translators, we really had the benefit of a really unique resource in Washington State, and that was the Dr. Robert Bree Collaborative. So the Bree Collaborative was established by statute in 2011 to create a public-private partnership that focuses on opportunities to improve implementation of evidence in practice. And it's built through a broad stakeholder consensus-driven process. The Bree's work is organized around topics of interest selected by its board of directors with broad community input. The board itself is quite broad. I'm grateful to now be a part of that board myself on behalf of the Washington Health Alliance. And we were fortunate that this group had tackled low back pain in 2013, and we were able to use that as an important launch pad for our new role as the evidence translators for our purchasers. So I want to just sort of stop pause from the evidence just for a second here and talk about the tools in the toolbox. From the very beginning, from our very first conversation with our purchasers, we were orienting them to this concept of the tools in the toolbox that represent levers for change in healthcare delivery in this sort of value-based framework where the alignment of incentives is so important. And I think one of the reasons we felt this was really important to orient the purchasers to is they get laser focused in on the things they can control. Benefit design and communication, and don't always really see and appreciate their influence across the full spectrum of this. So again, it's sort of that mashup of the value-based construct and a collective impact model that was so important for them to see and understand. While they don't directly control provider payment or practice culture, they have a unique ability to influence that in some really meaningful ways. So when we came down to translating the evidence for the purchasers in the terms that we felt that were relatable and accessible for them, and also ways that they could relate to them being actionable in both the ways they could control as well as the ways they could influence, we started with the basics that non-invasive treatment options help 95% of people with low back pain recover after 12 weeks, that many recover with minimal intervention after 6 weeks. We highlighted that where an individual seeks care is associated with differences in utilization and outcomes. We talked about studies that look at primary care versus chiropractic care versus physical therapy as starting points for low back pain. And we also talked about the really important role that benefit design plays in terms of how we access care, the choice of providers that we make. And we kind of took it down to this concept of the door you walk through matters. Knowing that with low back pain care, maybe you shouldn't even be walking through a clinical door sometimes, but to the extent that we're looking at what can we influence in the care delivery setting, you know, that was an important construct. And I would say that this conversation really highlighted, I think, how far we've come with our purchasers, both in terms of their ability to be open and, you know, vulnerable by raising their hands and saying, Karen, I didn't know that you could go to physical therapy directly. I thought I had to have a physician's referral to do that. And in fact, our benefit design might require that. I'm going to have to go back and look at that. So I, you know, clearly underscored, you know, what the opportunities are here, and also reinforced the gaps that exist that we need to really think about. So in terms of deciding what to do, they settled on two strategies that they really bought into. One is a member activation strategy, really about communication and benefit design, and the other provider strategy around really getting the incentives in place to do the right thing, regardless of the door that the patient walks through. So I'm not going to spend a lot of time on those, to say that it really does represent that yummy PB&J sandwich that we hear about so much in this forum. So I'm not going to take you through this rather dense table, which is a tool that we use with our purchasers to walk through each of these strategies in more detail. But it was, I would say, I want to orient you to how we used it to map the evidence to action. So the columns clearly represent the tools in the toolbox that act as levers for change. The rows represent the stakeholders, and the contents of the table represent the evidence to action. And we felt like this was really an important construct for sort of driving home a couple of important points here. One is that in this kind of a framework, each stakeholder can see how their actions clearly relate to the evidence, but they can also see how their actions are reinforced by others or reinforcing to others' actions in different stakeholder categories. So again, kind of that mashup of the value-based insurance design framework and a broader collective impact model. And that's really where we are today. I will say that when we, I'm going to go back here for just a second, because the other thing I really wanted to say here is that when we presented this with the purchasers, the question that we asked them around these strategies is, if we have providers and health plans willing to come to the table to work with you on implementation of these strategies, is this an endeavor that is worthy of your time and attention? And the answer to that was an overwhelming yes. I didn't talk a lot about, but happy to answer questions about how we convened the purchasers and how separately, and then how we worked with the providers and the health plans together. But I will say, when we came together with the health plans and the providers, the level of alignment and shared vision for improving low back pain care was significant. And in fact, we had the CEO of a large multi-specialty group who was with us at the table when we were talking about avoiding surgery, sort of said, you know, Karen, I think we ought to also add to that avoiding injections. So lots of engagement, lots of interest, lots of appetite for moving this to action. I think, though, getting to this point of energy and enthusiasm for working together on change, you know, we had a lot of learnings along the way. And I'm going to stop here and just sort of let you absorb. I've talked about most of these things already in my comments, and I think I took a little more than 15 minutes, but I don't think I did too badly. So I'm going to stop there and say, happy to take your questions.
Karen, Cliff, thank you very, very much. You certainly put a lot into the presentation. Karen, a couple things. One is, or several things. One is that I think we very, very much appreciate that you kind of started out with a timeline, like how did we get here? And the community checkup, the choosing wisely, and then your two iterations, the first do no harm report. So the historical context was excellent, that you grounded this in data. And some folks may have some questions about kind of what comprises that large data set in the state of Washington, that you look at both sides of the coin. You look for low value care opportunities and high value care opportunities, which was very helpful. Like very much the way you've already acknowledged and pulled in some of our participants here. Milliman was a big part of what you're doing. Arnold Ventures is a big part of what you're doing. And then something that seemed to catch somebody's attention. And I'm going to ask you, I'm going to kind of tee you up for a question later, which is, what really grabbed decision makers' attention the most. And one seemed to have been that wonderful parallel line graph with the purchasers and the other state plans, and how they both went down over time in low value care per thousand, but the purchasers were still higher than the others. And I'm just wondering if that was a grab their attention moment. I like the way that you went over what the actionable, doable, and meaningful, that sort of troika of what will also be kind of guiding our next steps forward. You laid out the roles of trusted convener, transparent reporting, identify the problem, applying the evidence, and informing action. That was a very clear, a lot of clarity to that basic schematic was helpful. And then you laid out, gosh, I guess a half a dozen tools, quality measurement, practice culture, provider payment models, benefit design, and patient engagement. And then ultimately you wrapped it up very nicely on your mapping evidence to action grid, which also had roles for stakeholders. So it seems like that is yet another tool, a really important tool. So with all that said, I'll mention that folks can raise their hands, and I'll try to find those. I'll try to monitor the hands raised as well as the chat if I can. Karen, when you look across this kind of set of accomplishments here, what in fact were the most persuasive things you did? Was it the graph that caught my eye, or what were the kind of things that caught attention and did lead ultimately to action?
Wow. I think it's hard to say. It was a combination of so many things. And I will also say that this work is not for the faint of heart. And I think that the years of trust building that the Washington Health Alliance has been about has been an important foundation for this. It's not to say that you have to have been at this for 15 years to be successful. I think you have to come to it though with sort of a genuine intent to improve value and recognize. And then one of the reasons we did very specifically make this not about just addressing low value, but improving value was really, I think, an important way of messaging this, that folks who hear, I'm coming after you to get your low value care, hear it differently. I think when you talk about, we'd like to really improve the value of care. And when you get it down to something where I think the evidence base is as clear as it is for low back pain, I think you can also get a lot of agreement that it is the right thing to do, even though that means we all might need to do some hard things to get there. And I think that was really clear when we brought the purchasers together. And then I'll just say one other thing quickly, that this work also, I think, requires a lot of both collective and individual conversation. There were times when we had to do a lot of just coaching and cheering on the sidelines for folks. And then there were other times we had to run to catch up with folks who really were ahead of us in their thinking about how far they wanted to take this. So it's a combination of all of the above, I would say.
So what about champions, Karen? In your audience of stakeholders, was there a championing effect where some prominent player made a move that kind of dominoed into other players making a move? Was that part of it as well?
I think for us in our state and in our organization, the Boeing company has been a leader in this work in many, many ways. And I would say that having them at the table, they come to the table though as collaborators with everyone else, but having their experience of having done the deeper dives with the providers and able to share that with the other purchasers. And in fact, they were one of those that was really helpful for us in terms of framing what's doable, because they'd been at the table trying to sort of drive some of this in conversation with providers in other settings. And they were able to say, you know what, focus on the stuff that is not some big philosophy of care conversation. Focus on the things that everybody can agree that the evidence around doing this is the right thing to do. We just haven't figured out how to operationalize it or make it work or, do those sorts of things. And it's more about maybe changing the way the workflows are arranged in a care setting more so than making big, care decisions that challenge a provider's or a physician's sort of view on what's the right thing to do.
Got it. One of the things that you emphasized was the bit about evidence. And so one kind of question that arises then is, we're aware of the Cochrane collaboration does systematic reviews, and the Agency for Healthcare Research and Quality has evidence-based practice centers doing systematic reviews and so forth. So there are various Up to Date is out there as a commercial group trying to do things that look like distillations of evidence and so forth. Did you find, Karen, that because a couple of your slides looked at evidence, was it necessary as well as persuasive to have a credible organization being the one to pull together, synthesize, and distill findings from basically the scientific literature? Was that a big player and persuasive action getter, as it were?
Yeah, I understand your question correctly. I think
where did the evidence credibility come from? Yeah.
Yeah. Well, I mean, I think there's an appreciation and recognition that the evidence is credible in and of itself. It comes from peer-reviewed articles. It comes from, clinical trials. It comes from really valid resources. I think for me, the gap is in translating that into what does that mean for a benefit design for a purchaser, and I think the fact that it came from the Washington Health Alliance in terms of bringing this all together and helping them understand it, they know it starts at home. They know us, they trust us, and they can hear from us, I think, what that means to them. But there is a gap. And I will say, so I've spent a lot of time as a benefits consultant. I spent the last 10 years inside a health plan. I will say that's another place where there's a very, very interesting opportunity to improve the translation of evidence into action. And it's sort of the combination of all of those. I think that is really central to making this work in practice. And I don't know if I'm answering your question very well, but I think there's layers and layers of how do you make this actionable in practice that I think we really need to be thinking about.
Yeah, that is helpful. And I'm wondering, the reason I ask that is that how much of this really rests on the validity of the peer-reviewed literature and the scientific evidence and systematic reviews and meta-analyses and all that, insofar as the people that actually make the decisions, or is it that your alliance says we got to do it, or that some champion in the field, whether it's a large purchaser, a large employer, a Boeing, for example, what kind of gets people over the hump and saying, by golly, we do have to make a policy change here?
I'm not sure if I know the answer to that today. Because I think what we have today is agreement that we want to work on this and we want to implement this. And we know that some of the purchasers, the 8 purchasers that we are going to be working with, are going to do this. But I also think it has to do with critical mass in the market. So, our aspiration is to take this to the next level and to look beyond just these 8 purchasers and to engage other market segments like Medicaid and the state-based exchange, which represents a growing number of individual lives in the market. And I think it's interesting, it's not one mover, but it's sort of like, can we all move together? And there's some sort of comfort, I think, in that, in knowing that, oh, we're all gonna do this. So I think, so it makes sense, I'm not out there on my own.
And that sounds a little bit like the doable. You had actionable, doable, and meaningful. Part of the doable is if I see others starting to do this, maybe I don't have to be out there alone, sticking my neck out by myself. There is some sort of groundswell of trying to make a move on this. I want to call it Beth Bortz. I'm going to call on you. And Beth, the reason I'm calling you is that I want to look at 2 states on opposite ends of the country. Beth, without giving away your cool stuff on your member update later on, Beth, how has what you heard about Karen Johnson's experience in Washington fare versus or contrast with, Beth, your experience insofar as getting stakeholders on board and making something happen? Beth, I hope you don't mind that I'm calling on you.
I do not mind, Cliff. I'm here. I would say that there's definitely some similarities. Part of our Smarter Care work, we have convened an employer task force to drive some of the change, because one of the biggest challenges that we see is that while our providers are working really hard, if the incentives don't change, that they're going to get really frustrated because they're actually losing money by reducing low value care. And and I think we have agreement, to Karen's point, I think with our employer task force, we have agreement of the employers wanting to do something. I'm just eagerly watching Washington, because I will say that we struggle getting the employers to actually pull the lever. They agree they want to do it. We've agreed to, you'll see in my report, some measures they want to work on. But when we say things like, are you willing to tier your network? It's pretty quiet.
Well, Mike Chernow better be taking notes on that, because he's going to try to say where a breakthrough could happen by the end of the day. That's an important note to be taken. Beth and Karen both, is it also your experience that across the big purchasers, the large employers, that there's a range of interest or willingness to get on board here? I'm just remembering from some of our original low value care task force meetings that there are some employers that really took the lead, and some that kind of were just sitting quietly and not ready to pursue that. So I want to ask you both that. Then I'm going to go to Chernow for a question.
I would just say absolutely. There's a difference. Some of it depends, truthfully, for us. We've had more trouble with the national employers than the large Virginia, because in Virginia, they can actually, engage at a national level. They don't want to do open off in Virginia, right? For just their Virginia employees. So that's been one of the challenges.
So if you are a national company, you've got to think, well, it might work in this state or that state, but I've got to make a national commitment. That's a tougher hurdle. Karen, does that sound familiar to you?
That resonates for sure. I would also say that, the purchasers, the employers, many of whom continue to be incredibly successful despite all of the challenges that we've been through in the last couple of years, particularly in the tech sector. And so we have the benefit of that, but the challenge of that when it comes to not so much of an appetite, no cost pressure, or not feeling the cost pressure to make sometimes some really hard decisions. Where we think there's an opportunity to have impact is in the mid-market employer. And I think that there are, and we're actually having some conversations about how to more actively engage the mid-market purchaser who may not even be self-insured, but collectively, they represent significant numbers of employees, particularly if you look at it regionally. And we think that there is an opportunity to engage them in ways that they might act more boldly than sometimes the most visible purchasers do. We think there's a real opportunity there. And Cliff, I see someone has their hand up as well.
I see, yeah. And we've got that lined up. I don't want to lose this point. The interesting contrast you've made between the big ones out there and the mid-market opportunity. Maybe they're a little bit more flexible, ready to make a move, easier to overcome inertia, and that though perhaps one by one they don't represent a lot, but there are so many mid-markets out there that there's a grand opportunity.
I want to add just one real quick point on that too.
Sure.
The other way to connect with those mid-market purchasers is through their benefit advisors. And the benefit advisors for us are also our members. They are members of our organization. And so we're having a lot of conversation with them about how do we help you help your purchasers more effectively. And so we're eager to sort of explore this topic in conversation with them as well.
Well, Cheryl Larson, who knows quite a bit about this, put a nice comment in the chat, very much agreeing with you, and she knows of once she speaks. Mike Chernow, you've got your hand up. Mike, do you have a comment?
I do, Cliff. Can you hear and see me?
Yes.
So Karen, that was really spectacular. My talk later in the day is going to be about how we have to do more and ways we might do that. And your talk makes me think I'm going to have to make a caveat to my comment that we haven't made enough progress, because you've really done an outstanding job. But one thing that struck me in your presentation was the role of measurement, which you know is part of this task force is emphasized a lot, and you've been working with Milliman to do that. You not only measured once, you had continuous measurement, or I assume you did, in order to generate that graph that you showed us. Can you talk about the importance of measurement and more importantly, continued measurement in driving both the action and building the momentum for all of this? It's an important issue because conceivably people might just say, okay, we're going to try and do this without investing in the measurement activities. But you really relied a lot on the measurement, and I'm interested in the role you think that's played.
Well, yeah, I think the measurement and the data grounded the ability to have a discussion that led to collective decision making. I mean, it was pretty straightforward. I mean, we could have gotten, I think we could have gotten close to where we ended up without having our own data or the purchaser specific data, but it certainly accelerates the conversation. And the one thing I think I want to be careful about here is I wouldn't want to put so much emphasis on like the purchaser specific data in a way that makes this inaccessible to those who can't do that kind of analysis using their own data. Because I do think the other thing that the data and the measurement over time has underscored for us is these are persistent and pervasive problems that have not gone away. And so it is not necessarily required that I mine my own data as a purchaser, for example, to know that I've got low value care in these 10 categories. So I think, you know, it is an important tool, and it does help to sort of drive action in very specific ways for specific purchasers. But I think we can also take that data work and apply it more broadly in ways that it can be translatable and actionable for many.
So, Cliff, can I just ask a follow-up question? So that was really interesting, although I hope you get to stay around till the end, Karen, because I may go to you first in my set of reactions to my comments about how we might build momentum for this around the employers in a more concrete way than the lifts that you've done and that Beth has done, where you have big coalition activities. And so I think this is going to be a really interesting theme as we go forward, because I actually think we may be able to, and we will see in the last session, push some specificity and some concreteness behind some of these activities to move in places where we haven't yet seen as much movement. But I'll wait for your answer, and that's probably going to be near the end of the day. So anyway,
I'll be here.
Thanks.
Good, thank you. Thanks, Mike, for those points. Just a program note, heads up to Carlos Orance. We're going to come to you, Carlos, before the bottom of the hour. Just want to make sure you're aware of that. Karen, just an inquiry about the data, please. Can you just remind folks what comprised that data set? You mentioned something about data being more use, people having either greater or lesser access to their data and or analytical capabilities. Can you tell us what's in the data set, and then a little bit more about who gets to use it and how credible it is?
Yeah, so the data that the Washington Health Alliance holds represents the commercial and Medicaid markets in Washington state. It is a little over 4 million lives, and we have data that is going back about 13 years, actually. And all of the data that we rely on for our reporting is provided voluntarily by health plans and or large self-funded purchasers in our state, including the Medicaid program. So we use that data for all of the reporting that we do. Milliman is our data partner, that works with us on all of the reporting that we do. And Nancy's on the phone too, or on this call, Nancy Ginter, our executive director. If there was anything that she wanted to add, I would welcome her comments regarding the data as well.
Yeah. Nancy, you want to speak up on that, please?
Well, Karen nailed it. She's got it exactly right. I think something that distinguishes our database in the country, honestly, is the level of ERISA plans that voluntarily submit, about 550,000 lives. And it isn't just quality metrics that we're entrusted with. It includes billed, paid, and allowed charges. So it's a very robust voluntary effort. And, honestly, we're humbled by the amount of trust that folks put on us to make use of this in the right way. And they engage
Excellent.
with us and drive the work. That's why they do it. They trust us because they drive the work with us.
Good. I want to do a setup here. Nancy and Karen, don't go away. I'm going to, in a moment, ask for some of our kind of chief medical officer people for some comments. And I know that Mark Friedberg's on, Mike Sherman, Ira Klein, perhaps others. Want to hear CMO reaction, if you don't mind. Back to Karen and Nancy. I'm not sure how often this question comes up, but certainly it's in the political context these days when we look at data and unintentional biases in data. Because your data spans ERISA and Medicaid, you've got a pretty good distribution of people across the state from a socioeconomic standpoint. Are you looking for, or have you seen any important findings regarding low value care versus high value care access and utilization by people as they might differ in those socioeconomic sectors that might be relevant to our discussion?
This is a common theme of conversation across all of our committees, whether it's the Health Economics Committee, which is really looking at cost and utilization and represents a lot of the smart sort of actuarial and health economist types in our members, or the Quality Improvement Committee, which is our clinical leaders, or our purchaser group. And we actually just completed the evaluate process, which we do with the National Alliance of Healthcare Purchaser Coalitions, where we do a deep dive with the health plans. And one of the challenges that we have is, how do you measure that when the race, ethnicity, and language data is so sparse and not just, and there's myriads upon myriads of issues there. We are exploring currently with our committees the ability to use some proven methodologies. Namely, we're looking at the Area Deprivation Index, Advanced Neighborhood Atlas, as a mechanism for dividing, looking at our subpopulations in a more impactful, to understand what's impacting, who gets what. As it relates to this. But yes, certainly I think from the low value perspective, we've had a lot of conversation about that, as well as the high value perspective. I mean, they're just mirror images of one another, essentially. So yes, very focused on moving that forward in terms of the work that we do. And I think also, Nancy can speak better to this, but I think there is a real shift that we're seeing with our purchasers, who at one point said, no, we're not going to give you that data. We're not going to tell you what we know about that. And now all of a sudden they're like, how much can you tell us about how this looks for different portions of our population? So seeing a real shift there, especially from our purchaser perspective.
It's such an important point, and it is closer, at least now, to top of mind among many of the stakeholders as well. Area Deprivation Index, I'm a fan. I can't believe you mentioned it. I don't hear it very often, but as I recall, there are 17 socioeconomic variables. And those variables are highly, highly predictive of health outcome disparities and health access disparities. And I think was originated at the University of Wisconsin, if I'm not mistaken. Very, very useful tool. Thank you for that. Thank you.
We're actually reviewing that with our Quality Improvement Committee this afternoon.
Oh, you are. It's a really, we're starting to use it as well. Very important tool.
And Beth is saying they've done it in Virginia.
Oh, good. Okay, good. Any of our chief medical officers, Ira Klein, Mark Friedberg, Mike Sherman, any comments on what you've heard here vis-a-vis the state of Washington and relevance? And just speak up if you can.
Hey, Cliff, this is Ira. I could start just with a little bit and let the rest of the gang follow up.
Okay, Ira, go for it.
I think when you're looking at this data, and so if we look at low back pain, we definitely have to segregate by line of business, because as you pointed out, social determinants of health are different. Different groups use care differently. They may not have the same benefit designs. and the measurement has to be specific to the geography, what practices they use, how they use care for other like services, and what are the approaches and incentives of the providers. Do the providers they see, do they take risk? Are they in a full risk contract? Because that may change a lot of the approaches. And then think about what are the other comorbidities in the picture. And I'm sure my colleagues will have others.
Good, thank you.
On the comorbidity front, I would just share that with this data, we're only looking at low risk subset of patients. So we understand that, right? And we do agree with your comments about practice patterns, and frankly, would like everyone to begin thinking from a valued basis whether they are being paid fee for service or not. That's what we're driving.
Great. Thank you very much for that point, Nancy and Ira, for the comment. And again, I know that Karen mentioned this, but Beth Bortz did also comment about their use of the indexes and so forth over in Virginia. Any further comments from CMO types on the call? Ira, thank you very much. I'm not hearing any right now. Okay. Karen, what's your wrap-up line to us? What's the last thing you want us to remember about what you presented going forward? If there's one thing we need to learn from your experience in the state of Washington, what might that be?
For me, I think it's, this is doable. It's doable. That's the big message here. But I think for me, one of the greatest insights of this is how important measurement is for identifying the problem, but you have to understand the evidence to know what to do about it. And I think it's really understanding and applying the evidence in sort of really tangible, actionable terms that stakeholders can relate to. And I'm thinking specifically about purchasers who we need to be drivers in this work. If you can accomplish that, I think you can start to move to action quickly. I think there's an appetite for this.
So you're really making it as a primary kind of bulwark, or in the foundation of this is you better have the evidence. You need other stuff, but if you don't have the evidence in a credibly presented way, you're going to fall apart ultimately. And I don't think, no one's mentioned the GRADE process yet in the call, but again, GRADE has a process for reviewing and synthesizing evidence. Cochrane Collaboration, HRQ, and others are getting really good at this, and there are great resources for folks looking for evidence credibility as well. And of course, Karen, in the state of Washington, you've done such a great job of demonstrating not only how you pull it together, but how you apply it. So thank you, Karen Johnson. Great start. We really appreciate that. Great start, Karen. All right, let's move on now. And so our next presenter is going to be Carlos Arance from the David Geffen School of Medicine at UCLA. He's got a bunch of other titles that go with it as well, but those are some of his current titles. Carlos, you're going to talk to us about some very important connection, as it were. This is an ongoing connection that everyone needs to understand between the low-value care movement and U.S. Preventive Services Task Force and how they grade out their recommendations. I already see grade D services up there. We need to understand it. We need to follow this. It is written into law in a certain place or two. And so giving us an update about how this is playing out, and that will be very valuable for us. So Dr. Arance, you're on.
Great. Well, thank you very much for having me, everyone. My name is Carlos Arance. I'm a second-year fellow in the VA UCLA National Clinician Scholars Program and a health services researcher. It's really great to follow up on Karen's presentation and discussion, because I think when we're talking about evidence and how to convince stakeholders, there's often disagreement about what the evidence shows, and I feel like what I'm about to present today is going to be a nice complement to that. So I'd like to start off with a clinical case from residency. So I'm trained as a general internist, and I completed my residency about 2 years ago. But I was in the hospital one night, and I met a patient, an 88-year-old man who's independent at baseline, lives alone, can take care of all of his ADLs, and had a history of hypertension and dyslipidemia. So very healthy man at baseline. He underwent a screening colonoscopy. And during the colonoscopy, he had a large polyp removed, had a lot of bleeding. And so the GI that performed the procedure wanted him to be observed overnight just in case. And so as the senior resident at the time, our team admitted him. And it's really unclear what happened after that. Maybe there was some delirium, maybe there was an aspiration event, but very unfortunately, this 88-year-old man suffered an in-hospital cardiac arrest. And as the senior resident on overnight, I responded to the resuscitation, and he fortunately survived. However, he experienced severe deconditioning, eventually was discharged to nursing home, although he did survive this whole ordeal. But I think this case very dramatically illustrates the potential harm of low-value services, as this audience is very aware of. And in this case in particular, when we did some chart digging after this all happened, we realized that this screening colonoscopy was a grade D service. So it was a service that the U.S. Preventative Services Task Force highly discourages clinicians from providing to patients. And that's because the potential harms exceeded the benefits. This patient had no further comorbidities, no family history, no history of IBD, and no signs or symptoms that would have warranted a colonoscopy. So while low-value services cause significant harm to patients, as many of us are aware, they also threaten the healthcare system as well as Medicare and the ability to provide other high-value services. So again, the definition of low-value services are those in which the benefits do not exceed their potential harms. And as we're aware, it consumes greater than $101 billion in healthcare spending annually. And older adults in Medicare are particularly vulnerable to receiving a low-value service. One of the most well-known estimates suggests that 43% of older adults had received a low-value service in the past year. However, rates of low-value services have remained flat in the past couple of years. As John Maffei has shown in an analysis published in JAMA Network Open, low-value services have remained about the same within the Medicare fee-for-service program. And that's all in the setting of choosing wisely and an increased awareness among clinicians of low-value services. And so that really brings to light the question of how do we reduce low-value services and how do we measure them, and maybe focusing on a group of services in which there's wider agreement that these services don't provide any additional clinical benefit might be an area where we can bring multiple stakeholders on board. And that's where the U.S. Preventative Services Task Force recommendations come in. And so I'm sure many are aware the task force rates preventive services on a scale from A to D, and services that are rated A and B are those that the task force recommends that clinicians order for patients because they provide a substantial or moderate benefit. They rely on systematic reviews, meta-analyses. A lot of their reports, of course, use the grade criteria to evaluate the evidence. So there's a lot of agreement that these are definitely things that we should support. Grade C services are those in which there's a very small benefit, that there's much more uncertainty to the evidence, and that the task force recommends that these services are only ordered in very select cases. So as an example of that, colon cancer screening in older adults between ages 75 to 84 carries a grade C recommendation. Now, grade D services are those in which the evidence clearly show that there's no net benefit, and the task force recommends not ordering these services. They are very clear that the evidence strongly supports that assessment. Grade I services are those in which the evidence is really unclear. And so I think this is a really important delineation, because oftentimes in the low value care world, we often talk about some low value services and labeling them as low value because there's not evidence to support them. But that's sort of the equivalent of this gray area of grade I services. So if we focus on these grade D services in which there's really no net benefit, this might be a very actionable area for clinicians, health systems, and payers to think about. Looking at the prior literature, there's been very few studies that have examined grade D services, which is what motivated this analysis with several co-authors, including Mark Fendrick and John Maffei. So the objective of this analysis was to estimate the utilization and cost of 7 USPSTF grade D services in Medicare from 2007 to 2016. To do this, I obtained data from the National Ambulatory Medical Care Survey, which is a nationally represented survey collected by the Centers for Disease Control. US Census Bureau representatives go out across the country to all 50 states and abstract data directly from the medical records of outpatient clinics. And so because they're getting data directly from the medical record, the data available in the NAMC's data set is very detailed and includes data on patient characteristics, their comorbidities, their diagnoses, what kinds of medications they're receiving, as well as some characteristics about the physicians and the clinics that they're seeing. So in this analysis, we calculated the rates of 7 grade D services that were ordered throughout the study period. And then we took these numbers and multiplied them by publicly available Medicare allowed prices to estimate the spending on this group of 7 grade D services. So these 7 services are depicted here. They include 3 cancer screening recommendations, so prostate, cervical, and colon cancer screening. They include 3 screening tests for very common conditions, so cardiovascular screening, asymptomatic bacteriuria, and COPD screening, and then 1 treatment service, so vitamin D to prevent falls in postmenopausal women. So ultimately, across this 10-year period, we identified 189 million encounters in which a grade D service was ordered out of a potential denominator of about 2.4 billion visits across the 10-year period. And as you can see, the average age of patients who received a grade D service was about the same as those that did not receive a grade D service. Moving on to the main findings. Here I'm showing the annual utilization, the annual count of these grade D services ranked from the most frequent to the least frequent. And here on the y-axis, each bar corresponding to how many times this service was ordered in that year in millions of orders. So the 2 most frequent, as you can see on the left-hand part of the slide, included asymptomatic bacteriuria as well as the vitamin D supplements. And there's a sharp drop off in the annual utilization. And you can see that colon cancer screening for adults over 85 was ordered the least frequently at about 140,000 instances per year. However, when we look at the spending on these services, we can see that that there's a disproportionate number that are attributable to colon cancer screening. So even though colon cancer screening was the least frequently ordered of these 7 grade D services, it actually was the 3rd ranked service in terms of estimated spending across the 7 services. Again, asymptomatic bacteriuria and vitamin D supplements were the top 2, and that was simply because of their sheer volume of ordering on an annual basis. So pulling this all together, just to summarize, so over a 10-year period among Medicare beneficiaries seen at outpatient clinics in this nationally representative data set, we observed that Medicare enrollees received about 31 million instances of low-value grade D services. And these 7 services in total comprised about $478 million of annual spending. And again, these 7 services are just a slice of the total grade D services that carry a grade D recommendation, and there are about 20 in total. So this has a number of implications for thinking about how do we curb low value care. Well, I would say that these findings suggest that this is a good place to start, and perhaps as others have tried to do across the country, that maybe we can pilot some payment reforms, such as not paying for grade D services. One really dramatic example from the past year came from Canada. So in Canada, Ontario decided to not pay for vitamin D screening. And what they observed was a dramatic drop in utilization starting in 2011 when this non-payment policy went into place. And we can see that in comparison to the United States, depicted on these orange and gray lines, that vitamin D screening continued to increase. And this was all still when choosing wisely was happening. Now, this is something that CMS can potentially do, as the Affordable Care Act under Section 4105 actually grants the Health and Human Services Secretary the authority to not pay for grade D services. This is a policy that could be implemented in a pilot phase, and perhaps one of these 7 grade D services could form the initial pilot. And if it's shown to be successful, could be scaled up to the rest of the grade D services. Now, such a policy would really require careful attention to unintended consequences. And I'm really glad that Karen and others have brought up the importance of equity, because we want to make sure that if we are curbing low value services, that we're not doing it in a way that it widens disparities. And at the same time, we can take some of these savings and reinvest them to provide more high value services and perhaps reduce disparities in high value care as well. So with that, I'll pause and happy to take any questions and start the discussion. Well, thank you.
Thank you very much, Dr. Onse. In a moment, but not right just yet, I'm going to go to Katie Spangler, who I think has some comments on 4105 and a few other things. Just to kind of not lose the point about the importance here, Carlos, USPSTF has been around for a while. Sometimes they're under the radar, but every now and then they'll come up with a recommendation that flies in the face of conventional care and or certain stakeholders. And I'm thinking of mammography, which isn't quite a hardy perennial, but it is pretty hardy. It comes up. There's some of the other kind of things that the task force has weighed in on that have caused attention. Typically, when they say don't do this kind of thing or don't do it as often, it would seem lately that there is this opportunity, what with the attention on the A's and the B's, that kind of the positive end, that now might be the time to look at the kind of the negative end, which is the D's. Do you see sort of in the political or scientific context that this is the time to make this move toward focusing in on the D's and kind of saying, we're not going to pay for the D's?
Yeah, I think the grade D point is really important, because we've seen a proliferation of recommendations in choosing wisely, for example, and it's almost like having a more parsimonious set of actionable items to focus on is where I think it would be easiest to kind of gather that consensus. And because the USPSTF comprises, clinicians, I think that carries a lot of weight itself. And I think that if it's done carefully and attention is given to every stakeholder, and we're addressing the concerns of, say, the American Cancer Society or some groups that may disagree with the USPSTF grade D recommendations, and I think that it's still possible to really focus on grade D and gain traction on it from a policy perspective.
Good, thank you. And again, could you make the point, the important distinction you made with regard to the top 2 in terms of utilization were clearly the asymptomatic bacteriuria tests and the vitamin D supplements, but it was colonography that had a disproportionate impact on costs. So you're not saying to focus on any one of the top 10 in particular, just saying if it's a D, set it aside. But any other observations about volume versus total costs insofar as opportunity?
This reminds me a lot of the work that was done in Virginia and that John and Marcos had published on a few years ago. But, we shouldn't ignore like the small things that in aggregate actually comprise a large amount of spending. But at the same time, we should also find, the procedures that also have a high per unit estimated cost. And that might lend itself to different strategies, curbing frequently ordered low value services that carry a grade D recommendation might just require perhaps simple changes in default ordering, simple nudges that are embedded in the EMR. because perhaps clinicians are just sort of on autopilot, whereas something like a grade D recommendation for colonoscopies, that carries a little bit more emotional weight, and perhaps interventions in that area require much more shared decision making, much more intensive sort of type of intervention to really curb those the rate of ordering for those types of services, if that makes sense.
And then one more question before we'll go to Katie next. Can you say anything about the cascading effects? In other words, if we run a type D test, when you're talking about the cost, was it just the test itself or the kind of downstream impacts as well?
That is a great question. So we focus simply on the index event, so just the service in question. So that's a very good, important point, because then this is probably an underestimate of the true spending that occurs. I mean, I think about the work done at Harvard that looked at cascades following unnecessary EKGs, and you saw that, you know, led to a stress test, led to coronary angio, possible stent placement, you know, all of those things in aggregate really add up. And it's not just the spending, it's the actual patient harm. I mean, I had a very vivid case from residency where a patient got a huge amount of contrast load, and that ended up in a whole fiasco with the patient requiring dialysis temporarily.
So those downstream costs are something to kind of keep in the back of our minds. Well, maybe the fronts of our minds, I suppose. But I'm glad you addressed that as well. Thank you. Katie Spangler, you're in a pretty good position to provide some commentary and some other perspectives on this from a political context as well. Katie?
Much, Cliff. And Carlos, I imagine I can speak for a lot of folks to just say thank you so much for the very excellent presentation. I think you did, you know, a fantastic job laying the groundwork or kind of building on the foundation that this group has been building for a while, about how decreasing low value care, the importance not only from the patient standpoint and particularly just the patient safety, or, you know, making sure that they're not unnecessarily exposed to harmful care, but also from the cost side. And then, you know, the success story from Canada, I think it would, that chart will be ingrained in my mind for a long time. So I appreciate that very much. So at the Smarter Healthcare Coalition, as this crew knows and has heard from me in the past, you know, we are working to try to take a lot of the great work that this group does and make sure that policymakers within the administration and the Hill are aware of it. The Smarter Healthcare Coalition for a while has worked to employ kind of a dual track strategy as far as not only working with the administration, and you know, we had sent a letter that I know this group has seen a copy of to Secretary Azar with the previous administration. We had great follow-up conversations kind of pointing out the language that already exists within the Affordable Care Act, Section 4105, that would allow the secretary to not cover the D-rated services. And we made, I think, really good progress with the previous administration. And so we are looking forward to continuing that conversation with this administration. We have a revised letter that we plan to send to Secretary Becerra soon. We'll make sure that this group gets a copy of that. But that's kind of track one of our dual track strategy, is working directly with the administration, and the asks specifically in that letter are one, that the secretary would utilize his authority to no longer cover these D-rated services within the Medicare program, either kind of writ large, which I think you know, might be a tough pill to swallow, but if not writ large, then kind of, as Carlos had mentioned, perhaps through a demonstration authority where you just kind of test the proof of concept. If it works, you can then expand it to the whole country. And so I think a logical avenue there would be to utilize the existing Medicare Advantage value-based insurance design demonstration program that has been expanded over the years. As this group has also heard said, you know, one of the few things that I think was started in the Obama administration and expanded by the Trump administration, you know, we're hopeful that we could expand it a little bit further under the Biden administration by specifically not covering some of these D-rated services. And then the third avenue would be to utilize existing authority to kind of build on some of the great work that Washington Health Authority has done, as well as Smarter Care Virginia, to allow some of these kind of state-based collaboratives to maybe get together and share information and share best practices, and maybe some type of a multi-state demonstration program. You know, there was $50 million that was appropriated in the Consolidated Appropriations Act, which was enacted last year, last year, that would that was for state all-payer claims databases. And so that money, you know, we could maybe ask for a little bit of that money to be dedicated to this kind of multi-state collaboration to share best practices regarding low-value care. So that's all track one. Track two, which the strategy there is to work with Congress to introduce legislation that would allow for these very similar things. And the thinking and the kind of success stories that we've seen in the past are that once you have legislation out there, particularly bipartisan legislation, and I feel very strongly that we would be able to achieve bipartisan introduction of some legislation to do those three things that I had said, that then kind of gives the administration a little bit of air cover to maybe then proceed with some of these things through the regulatory realm. And so that was an effective strategy with regard to the VBED Medicare Advantage demonstration program. So we kind of want to use that same playbook in this regard. And again, the three things would be the kind of further exploring the authority that already was created in 4105. The second thing would be to specifically amend the VBED Medicare Advantage demonstration program to give plans kind of more express ability to not cover D-rated services. And then the third thing would be to create these possibility for a multi-state demonstration program to really share best practices. You know, we've heard that a lot of states have eagerly watched what the success in Washington and Virginia and kind of have their hands up as far as eager to pursue similar paths in their states. And I think, you know, rather than reinvent the wheel, it would be great to try to coordinate the communications among the different states. And I know we have states on the call today too that have been a part of this scope for a while.
Yes. Katie, thank you very much. In a moment, we're going to go to Gwen Darian for a question. But I just want to confirm something, or just kind of run this by you, Katie, and that is sort of the political implications here for certain stakeholders. Each of the 10 things that Dr. Oronce laid out represents an ox that could be gored, at least from the standpoint of the stakeholders in those tests and so forth. And some of us can remember when certain federal agencies and other organizations were nearly put out of business when certain stakeholders saw their particular ox being gored, went to Congress and had funding removed and so forth, or threatened to remove it. Do you see any kind of, could that arise yet again, Katie? Or is the evidence and the strength of the other stakeholders strong enough to fend off the kind of pressure that would probably try to quash a movement like 4105?
Yeah, so I think that's the beauty of kind of how carefully this campaign has been constructed, right? And I know that just looking at ARC's experience with low back pain from several years ago has been, you know, enlightening to folks this time around, right? To say, you know, we are going to look and, you know, that I think that's the beauty of I think it was 2018, like the third most read health affairs article was the one that John Maffei and Marcos Dacry and Beth Bortz published, right? Looking at low value care, and to the point that Carlos made also of looking at kind of maybe the lower paying but higher volume services, right? So you're not, you know, taking away a large chunk of someone's revenue, but instead you're kind of just saying, you know, these are colonoscopies for older folks. Like, this is not the predominant revenue stream for your practice, right? And so really taking kind of it's been designed intentionally to take kind of smaller bites at the apple to kind of prove the concept and then expand it from there.
Good, thanks. As Mark Fendrick just reminded us, before ARC was ARC, it was AHCPR, and the low back pain had something to do with what Kay just mentioned. Gwen Darian, thank you for your patience. Gwen, do you have a comment or a question?
Yeah. Hi. Thank you. I actually was going to respond to Mark Fendrick's comment in the chat about addressing the more is not better is front and center on these issues, and what are thoughts here. And I think, you know, we've talked about this before, but it keeps on coming up. There are multifaceted parts of this. First of all, and I will say, as many people on this call know, much of my experience has been in the cancer space as a survivor and as a patient advocate. But it is what we were all told was that we were going to throw everything we had at this cancer. Then coupled with that was the sort of exhortation to go get your cancer screening, and that if you didn't get your cancer screening, in some ways you were not exhibiting the personal behaviors that would help you with your health. So when things change in terms of screening directives, it's incredibly difficult to change those public health messages. And people do feel as if things aren't being taken away from them. You know, Cliff had mentioned earlier the mammography debate, which has been going on and on and on. And it was in the paper again the other day, yesterday or today, about centers suggesting women 40 and over get a mammogram every year as opposed to every other year from 50 and older. And so I think that there has to be a marrying up of public health messages and engagement of people in different communities to help carry these messages. And communities can be communities of patient advocates, they can be geographic communities, they can be communities that represent different ethnicities or faith communities. But it's so contrary to so much of what we've had as public health messaging over the last probably century that I think it's very difficult to change that in a way that maintains the trust of the system and the trustworthiness of the messengers, as well as helping to kind of helping to flip this narrative that if you don't get a screening, that somehow you as a person are not doing what you need to do to take care of your health. So I don't know our comments on that, but that was my, I just commented on Mark's comment.
Well, great point. I'm just, Dr. Aronce, Carlos, so on one hand, and this is what happened with mammography, is I recall I think it's 20 years ago when this thing got really fired up, was we're trying to get people to come in for their mammograms. We're trying to get them to come in. We still haven't gotten there for people that need to have their mammograms. And now you're telling us that you want us to cut back on mammograms. It wasn't a real precise argument, but that was the sort of behavioral response issue that arose. Do you want to comment on that? I mean, some people need colonoscopies and they're not coming in. And if we start saying we ain't going to pay for these things, are going to run into trouble. Carlos?
I absolutely agree with what Gwen mentioned. And I love that we're having this conversation because it is something that I've been interested for so long. And when I had presented some work with community geriatrics groups, these were the messages that were also being conveyed to me, that for years, for example, Black women had been told to be extra mindful about breast cancer screening, given the well-known disparities in outcomes. And now we're saying don't get it. And after more discussion, it was that communication needs to be clear, both, again, from public health campaigns and from the clinicians. But perhaps one messaging that would resonate is the focus on the cascades. Because when I had presented, a similar anecdote about a cascade to that audience of geriatric organizations, they were keen on that somebody who received an unnecessary service actually had a very concrete harm. And I think that is perhaps maybe an important messaging point. And I think that engaging communities is going to be crucial because having their input and co-designing messaging is how I think the needle is going to move from a patient perspective.
Point very well made. Thank you. Katie, any further response to that, i.e. the behavioral response and the appearance of contradictory messages?
I think as you're looking at this from a federal policy perspective, I think it's incredibly important to have a really accessible exceptions process, right? So if there's a blanket rule that Medicare is not going to cover D-rated services, there should also be a pretty easy exceptions process in whatever instance, to the point that Mark put in the chat, right? Like whatever clinical nuance might exist, that would mean that older Medicare beneficiaries should get the colonoscopy. Maybe they had just finished a regimen of colon cancer treatment and they need to have the follow-up. So I just think the one size fits all isn't going to always work, certainly as there's a greater emphasis on social determinants of health in different populations needing different services. I think the exceptions process helps address quite a bit of that.
Katie, just to follow up on that directly, does the experience with the pandemic, which has in certain cases widened disparities in care, and our greater attention to barriers to access for some populations, including for important tests like these, does that make a little bit more of an uphill climb for 4105? Can we still make a concrete evidence-based argument, maybe with a cascading effect that Carlos returned to? Is that an issue now that's been heightened by the pandemic experience?
I really like Carlos's point about on the sorry, I just lost my train of thought. But I think from the patient harm perspective, I think that there's a lot there. I think also looking at kind of from the cost perspective, just the notion that healthcare costs, we had what I think of as like a temporary dip in healthcare costs during kind of the height of the pandemic. But I think a lot of that care is going to come raging back. I think you will have seen a lot of instances where people maybe didn't get the high value preventive care that they needed to be getting. And so we're going to see some longer term implications from that. And so from purely the cost perspective, I think that the opportunities for needing to address low value care are going to increase exponentially. I think also just from the point of kind of navigating social determinants of health, I think, there's also opportunities to look at low value care. In some instances, we're starting to see that the low value care is actually even worse for certain populations. And then that leads to greater kind of downstream effects as well and cascading effects.
Great point. It's important for us to consider, we've been looking at low value care for a while. Like we said, we're in our 9th convening, but stuff's happening now in our context that may change the perspectives on this. Thank you for that commentary, Katie. Carlos, just back to you for a final word. Any last take home point? What's the single most important thing we need to take home from that great research that you shared with us?
So I think that the take home point here is that grade D services are very much an area that have shared agreement across multiple clinician stakeholder groups, that they are frequent, that they're costly, and that this is an area where policymakers can and payers can start to really kind of move the needle on reducing low value care.
That's it. Great nugget there. Thank you very much, Dr. Carlos Arance. Very helpful. We are glad you did this. It's not only great content, the timing is good too. Thank you. In a moment, we're going to turn, you got it. In a moment, we're going to turn to Carrie Colla. But before I do that, I just want to acknowledge some folks I think I spotted come on. I think I spotted Emily Ahrens, Muna Banji, John Maffey, Troy Ross, and I think Hassan Azar also joined. So thank you for joining us all. It's been a great conversation. We're glad you can line up with us here today. Now, we want to turn to Dr. Carrie Colla from the Dartmouth Institute for Health Policy and Clinical Practice, among other things. She's also a professor there. And she's going to share with us some information about actionability here. And I like that she's mentioning actionable here in her talk, because we heard earlier from Karen Johnson, one of her 3 most important points was actionable, doable, and meaningful. So Dr. Carrie Carla, you are on, and I think we want to see your intro slide up next. There it is. Carrie, you're on mute and we're ready to go.
I was going to say, now if I can just figure out how to unmute, you have to like refine the Zoom window. Well, thanks again, everyone, for the invitation. I'm happy to be here. And I think this presentation and set of analyses does really follow on nicely from the prior speakers, and expand the discussion even further. And, some of the points are very similar. So I'll dive right in. Just want to acknowledge funding from Arnold Ventures, who I know are on the line, and many collaborators at Dartmouth and Harvard, including Nancy Morden, Ashani Ganguly, Maya Crawford, Wendy Yang, and Ben Usadi. So I'm the one here today, but couldn't have done it without them. So you're all aware of the motivation, but I just wanted to point out a couple extra things. And I know both that John Maffei's on and that Carlos also just talked about his recent paper, but despite a decade of measurement, I mean, I started working on low value care measurement, I think in 2011, and communication, choosing wisely, different types of communication, we can see from this paper that use of low value care really hasn't changed much. And one of the reasons we believe that that's the case is that it's largely been measured and reported at a national or regional level, kind of like you can see down below, which limits accountability and actionability. And then I also just want us to keep in the back of our minds in these discussions, it was just mentioned that the pandemic did stop a lot of low value care along with high value care. But as healthcare returns, and we probably are going to see a resurgence in low value care, does this give us an opportunity to kind of like reshape the discussion around these services and try to like suppress them moving into the return to normal care? And so can we think of this as like a moment in time to work on these particular services? So I know you're also familiar with the barriers to reducing low value care, so I really want to focus on the measurement. I know Mike is also going to talk later about incentives, but Mark mentioned our recent paper, Imagining a World Without Low Value Care Services, Low Value Services, the optimistic title. So I just wanted to note that like a lot of these barriers are discussed in that paper with Drew Crawler and Kevin Volpe. And but like you can see here, it's a big issue that others have talked about today too, the gap in accurate, robust, and actionable measurement of low value services. And our snapshot today is going to be point in time, but we realize that this does need to be ongoing feedback and measurement. So here's the paper if any of you want to take a look. So just to show you the evolution of measurement over time, even before I came to Dartmouth in 2010, the Dartmouth Atlas was measuring things that were not called low value services, but looking at differences in spending and kind of attributing potentially some of it to low value spending at the time. So here's an old graph from a paper by Chandra and Skinner, and also some data from the Dartmouth Atlas that shows that we have these 3 categories of care as a framework to think about this: effective care, heterogeneous care, where it's right for some patients and not others, depending on preferences, depending on your genetic profile, et cetera. So we're really going to focus on this third group, the low value care. And at the time, it was really about these broad categories of things, some of which could be low value or of uncertain value, where there's a bit of discretion. You can think about it in these services where we see these big differences between high and low spending regions. So to the right of the one means that higher spending regions have more of these kinds of services. So this is really where we see the discretion. But we also know in this category that there are lots of services that are high value and that we do need. So how do we get to that more granular level? So in 2015, we published a paper in JGIM that looked at low value care, specific low value care services in the Medicare population. And then we also used Healthcare Cost Institute data to look at low value care services in the commercial set of commercial insurers. And so you can see here the 2 maps. We did this at the HRR level, the hospital referral region level. But for those of you who know HRRs, they are based on referral patterns for hospital care in particular. And so what does it mean to measure at an HRR level? It's nice. It was, it was exploratory. It was the beginning of this kind of measurement. but how do you make that actionable? Simultaneously, we've seen a established provider consolidation. And particularly, you can see the difference just between 2016 and 2018 in this graph of physicians. And so going from about 40% of physicians being employed by a healthcare system to just over 50% in 2018. And this has been a long trend. And we also think that the COVID pandemic has accelerated this trend, as independent practices have really struggled to stay in business with the disruptions in care. So as part of the ARC Centers for Excellence of Studying Health Systems Performance, ARC put out with Mathematica the Compendium of US Healthcare Systems. And so this compendium, which has the data on the ARC website, I have the link at the bottom, has 637 of the biggest healthcare systems. But also the systems are defined in the ARC compendium as including at least one hospital and at least one group of physicians providing comprehensive care. So it can't be just specialists. And the hospital and physician group have to be connected to one another through either ownership or joint management. So relatively tightly connected, not just affiliated is the way I would think about it. So for these 637 systems, I just put a couple characteristics here to help you get a sense for what they look like. 70% of them are nonprofit, 20% public or government, some church operated and some for profit. And you can see many of them are like geographically centralized, at least by state, but there are 16 that operate across multiple states. And later I'm going to show you a map with some information, and we've just mapped the healthcare systems by their headquarters. And so when you think about systems and how they might play in low value care, there are a number of pros and cons to healthcare systems that we've begun to explore through research. And this research goes beyond low value care. But you can think about healthcare systems potentially having better, they're more likely to invest in IT because of the high fixed costs associated with IT. And so they're more likely to have consistent and rigorous quality measures available, and hopefully timely as well, which I know is problematic in lots of places. But in addition, efficient dissemination of new evidence programs and technologies. Healthcare systems might be able to invest in either third-party groups that provide this kind of information at their fingertips, or having their own centralized office that helps to disseminate and communicate different types of guidelines. And so at Dartmouth Hitchcock, for example, we have something called the Knowledge Map that works on protocols about different types of care. And then finally, the ability to leverage a shared culture. So if the culture is value, it might be easier to put some of the initiatives into play. On the flip side, we know that systems are in some instances associated with higher costs and have little incentive to reduce profits if they're making money on low value care services. And that we have a little bit of a further problem in healthcare systems that have both the referrers and the ancillary service providers, in that these in-house referrals may increase use of low value services if they've made significant investments in technology or infrastructure. And I just wanted to mention, Rick Roenick has a nice article there as part of the ARC U19 Centers of Excellence. There was a journal, a special issue of Health Services Research, and Rick Roenick has a nice article that talks about these pros and cons of healthcare systems, along with a bunch of research in that area in that journal. Okay, so what are we going to do and how are we going to do it? So we started with Medicare, 100% Medicare claims data, fee-for-service claims, and we use data for multiple years, but we're going to look at attribution of beneficiaries, Medicare beneficiaries, to these healthcare systems by looking at their evaluation and management primary care visits. So this is much like an ACO type attribution, where we assign patients to these healthcare system, these provider groups, based on their patterns of care. And we're going to do it over a 2-year period of 2016 and 17. And so just to give you a sense of our sample of systems, we ended up with 556 systems after we took systems out that either had very low attribution of Medicare beneficiaries, either because they're highly specialized hospitals or because they're, for example, children's hospitals. And we also limited the floor at 250,000 beneficiaries or greater. sorry, 250 beneficiaries or greater over this time period. So we ended up with 556, and you can see, but while that threshold on the bottom is low, you can see that most of these systems have far more patients and are quite large healthcare systems. But also I would say while these are all large, they differ a lot the systems differ a lot in the types of reimbursement models that they have with payers, how they came to be a large system, whether it was through an acquisition or a merger or through like slower growth over time. And they differ in a lot of other ways too, in terms of their population, whether they're academic medical centers. So there is, even though they're all large, there is some diversity within the systems that we're studying. So I know we have a lot of folks from Milliman on the call today. We use the Milliman Med Insight Health Waste Calculator in our analysis. And many of you are familiar with this standalone software tool that identifies potentially inefficient services. The Milliman Waste Calculator flags services as either necessary, likely to be wasteful, or wasteful. And just to be conservative, we only included the flags for the wasteful services in the estimates I'm going to show you today. We left out the likely to be wasteful services. We included 36 Milliman measures in our study based on clinician input of relevance to the Medicare population, for example, or other characteristics. I also wanted to note, so Milliman, when they create their measures, they the ratio that they're giving, the rate they're giving is the number of inappropriate services over the total number of services. And we really wanted this to mirror our prior work, which has to do with like who is the pool of beneficiaries as the denominator, and then the proportion who received the wasteful services. So we changed the denominators to be the pool of eligible beneficiaries. And so the way to think about the rates I'm going to show you is the percentage of the eligible patient population that received the low value care service. And I'm happy to talk about that more. To those Milliman, 36 Milliman measures, we added 5 that we created in-house based on things that we had done before and updated to be ICD-10, for example. So we added those in to the 36 measures to have 41 total. From there, we created a composite measure using 28 of the most common low value services in order to easily compare health systems to one another on overall low value service use. And the reason we limited it to 28 was really because we didn't want services with very small numerators or denominators to end up biasing or creating large fluctuations in our results. So to create the composite, we took the average of these 28 measures and converted it to a standardized score to measure distance from the mean. So in what I'm going to show you, a positive score means that you have more low value care services, and a negative score means that you have less low value care services compared to the mean. And if your score is 1, for example, you have 1 standard deviation above the mean in terms of your low value care services. Okay, so here are the 28 measures that we had in the composite, and I know that the text is a little bit small. So the x-axis here is the proportion of eligible patients receiving the low value care service. And so you can see here that the 2 most common are these 2 at the top, preoperative laboratory testing, which has gotten quite a bit of attention in the literature, and then PSA testing in men over 70. But you can see here that these box and whisker plots help us to see how spread out the distribution is over healthcare systems, over these 556 healthcare systems, and then also what the range is across the entire group. So whether there's more likely to be outliers in a particular service or whether systems look more alike on a particular service. And you can see we also took the Milliman measures and our own and categorized them into these groups, which were lab testing, imaging, cardiopulmonary and neurologic testing, procedures, and drugs. And we also looked at use of these services by these categories. And so we found that laboratory testing and drugs were the most used low value services. This wasn't surprising to us. Even when we analyzed the Choosing Wisely measures themselves in 2012 or so, we found that the most common types of Choosing Wisely recommendations were in lab testing and drugs. And so it's not surprising that that was the case. And it actually provides a little bit of, in part, we we discuss that as being because those are things that other people make money on, not necessarily the or prescriber or orderer. But also I think this kind of validates that those are important services to focus on as well.
Carrie, this is Cliff. Could you please go back to the previous slide? I think we want to absorb that for another set of seconds here.
Yeah, I'm sorry, I can't.
This is like,
that's being a request.
It's kind of a knockout slide, Carrie.
It's got a lot of information on it.
But so basically, the further to the right the box and whiskers are, the more overused is a low value care service.
Yes. And so think about if every single person who is eligible for the service, so we can take preoperative laboratory testing, and this is in low risk surgery. So we look in the data, we find everyone who has low risk surgery and then look back to see if they had preoperative laboratory testing. So if everyone had that, this would be a 1. So it's a proportion of people, and you can see at the very top the composite here. And so by nature, you can see it's centered on 0.
And so the stuff to the right of 0 means what? And the stuff to the left of 0 means what?
The stuff to the right of 0 means that, and so each of these dots here is an outlier system. That means that they're above 2 standard deviations from the mean. That means that they have more low value care services, and to the left means that they have less low value services on the composite.
And to say that they're using less low value services doesn't mean that that's the right number. It's just they're using less than others.
Yes. And I mean, the right number question is a good one. I mean, keep in mind what I said about us choosing to only include the ones that were considered wasteful. So in this case, I think, I mean, we all know that there are, you can't use claims to say, is this always correct, right? And in the past, I've used something like, you know, if you use a rule of thumb, do you want to aim for to be at the 10th percentile of different systems? But I think because we're using this more stringent definition of just the wasteful services, I think we can say here that we would really like these to be decreased in most cases.
Okay, so people are going to want to know if they can get access to this slide. And I think the next one, then if you don't mind, can you go to the next slide and just kind of reorient us once again?
Of course, I love that you're talking back to me. It's like talking to a with all the cameras off.
So tell us about the x-axis here, if you don't mind, as well as the y.
It's the same as the previous one. So average of low value care service rates. So the proportion of patients who are receiving the service averaged over, and the colors here are the same. So it's just combining those groups on the previous slide, those measures on the previous slide into a single score.
So this is like a higher order kind of aggregation, correct?
Yeah. And one of the things we wanted to do was to see how these things move together. And so I don't have this in my slides anyway, but one of the things we saw is that cancer screening measures, which we were just discussing, tend to move together. So if a particular institution does more low value PSA screening, they also tend to do more, I can't remember what, low value colorectal screening. And the other thing was within preoperative testing. So we have preoperative laboratory testing, but we also have other types of preoperative testing. And if you do some types of preoperative testing, low value preoperative testing, you're more likely to do other types of preoperative laboratory testing as well. And I just to say like a little bit about the bigger picture, I think one of the things we hope this data will be useful for is for each institution to go in and be like, what do I need to work on? And to be able to see across a range of measures in an area how they're performing.
Got it. Well, thank you for pausing on those 2 slides, and we wanted to drink that in a little bit more. We appreciate it. Thank you.
Yeah. I'm trying to think if there's I think a lot of people are familiar with the Milliman measures that are in the waste calculator. They're the ones we've been working on to a great degree for the past decade, and they're kind of like the usual suspects for measures. There's nothing in there that I find to be particularly controversial or in the 36, like I think they're pretty well established. I'll add. Okay, ready?
Oh yes, please go on. Please go on.
Okay. So I mentioned earlier that we made this composite index of the 28 most common low value care service measures. And that when you have less low value care, in this graph, you're blue. And if you have the least, you're darker blue. And in this graph, if you have more low value care, you're orange, and the darkest orange is the most low value care. And so, as I mentioned earlier, these systems are quite large, but we're graphing them by their headquarters or mapping them by their headquarters. And so just to give you a couple of examples, so this graph is actually interactive. So you can, I'm not going to do it right now just for time, but you can put your mouse over the circle and it will tell you what system it is, how many attributed beneficiaries they have, what their composite score is. And then you can go into the table and see how that system performs on each of the 41 measures. So just to give you a couple of examples, this is what it looks like if you go into the web version. And so you can't get all of these at once. It would be where your mouse is. We just did a couple of examples. So you put your mouse over this, and then Baylor Scott and White Health comes up in Dallas, Texas, and you get a composite score of 0.5. So that means 0.5. They are better on low value care because it's positive, and they're 0.5 standard deviations away from the mean in terms of being better at low value care. So I'll just pause here and see if there are more questions.
Well, you might have noticed that Beth Bortz is giving you convergent validity for the state, for the Commonwealth of Virginia. So she likes your blue and orange dots in Virginia, sure enough. That's great.
Yeah, and if you go back, I mean, you can definitely see a pattern here where there's more blue here, more red here, orange. So we haven't done any analyses to say like what's correlated with being higher or lower, but we're planning to.
Okay. We're going to want to know whether it's Beth Bortz or others, how you might consider putting to use. How do you start putting to use the visualizations that Carrie Cole is presenting? Back to you, Carrie.
Okay, so this is just the kind of stuff we can do. So these are the lowest relative users of low value care. And, you know, when you start to look at this, you start to think, okay, are these safety net hospitals then? Is it because they're not doing enough high value care or enough low value care? These are the highest relative users of low value care, and you can see a ton of them are in California. So this is just an example of what tends to be a little bit of outliers on the top end and the low end, but just to give you an example of the kinds of information we can get from the data. So importantly, how can stakeholders use these data? And I mean, you're the group that we see as the end users for this. So how can health systems use these data? As they choose their low value care reduction strategies, they can really think about, you know, do we want to start with laboratory services? And labs within the inpatient setting, at least, have gotten a lot of attention over time because of DRGs. So once all the lab services within the hospital were bundled into the DRG, we see hospitals working on how do we reduce our lab services. So when we start to look at the literature for interventions to reduce low value care, that's one of the places we see action because of the bundle. So working on incentive schemes within the organization, how the providers are paid, workforce education about these measures, and then hiring and retention decisions could also be influenced by these data, particularly if you're in a setting with non-fee-for-service payment. Policymakers and payers can track system performance over time, give feedback to providers on how they're performing, and create new policies and programs tied to the evidence. Health plans and payers, can use this information in contract negotiations and creation of high value provider networks. I just chose one example of this type of high value provider network. I don't know if we have anyone from Aetna on today, but Aetna has their Excel performance network where they do use some measures of low value care and lots of measures of high value care as well, in 12 specialty areas to designate these providers as being higher value. So that's just
we actually do have at least one or more people from Aetna. I don't know if they may want to comment in a little bit, but please do continue.
So this is my last slide. And just thinking about this as the point I wanted to make was really just to think about this data and information and measurement and reporting as one tool in a larger toolbox to work on low value care. As we've studied interventions to reduce low value care, we definitely realize that the best ways to approach low value care reduction is to use multiple different types of interventions at the same time, whether it's patient education, provider education, incentives, reporting. All of these things need to come together in order to have reduction of low value care. Just one of these tools won't do it on its own. So I just, again, wanted to mention our funders and my co-authors as well. So happy to take questions.
Thank you, Dr. Carrie Cole. This is great. We love your visuals and the data that back them up. I'm going to ask John Morgan to comment. John, something about a potential opportunity for Medicaid in the States. What did you have in mind there, John Morgan?
Cliff, sorry to interrupt. Some people are having trouble finding the hand raising function. And so I just wanted to let everyone know it's down at the bottom. Well, it's on your control panel under reactions. You can raise your hand there. So please do that during this discussion so that we can be as interactive as possible. Thanks, Cliff. Sorry for the interruption.
That's quite all right. Thanks, Susan Lynn. If you put Carrie's slides back up, or whatever the last one was.
Oh, sorry, that
John
was.
Okay. If you don't mind, John Morgan, did you have a comment, please, regarding Medicaid applicability?
Yeah, hey everyone, this is John calling from Virginia Medicaid. We're working, closely with Beth and trying to work closer to understand what levers are at Medicaid's disposal. And one thing that I know caught my interest is that as a managed care state, we don't really contract directly with providers, and at least I've perceived, some barriers at ensuring that incentives that the state designs really kind of penetrate directly to providers, because so often, while we have licensing agencies within our Department of Health, we tend to contract directly with our managed care organizations. But I know, one area of interest, and it's not under development, but at least in theory could exist, is that obviously the state is the vehicle through which health systems get large sums of money in the form of supplemental payments, which I think are often not necessarily tied to value or quality. And so I would be interested if other states have or are interested in thinking about how to potentially use really robust tools like this, which kind of normalize and draw from the evidence base a kind of unifying score that, at least in theory, could be that these supplemental payments could be attached to as a way of really attaching a very large financial incentive.
Thank you, John. Comment, Carrie?
So I'm guessing you don't see the claims then either from the Medicaid managed care organizations, right?
We do, usually delayed, but we do see them. But I think what gets tricky is that we set standards with our managed care organizations, but of course we do contract with them to a degree through our fee-for-service members, but it's admittedly a very, very small piece of the pie. And I think that's commonly the case across states, is that as more and more of us are reliant on managed care, there are fewer and fewer and fewer of our kind of actual funds that are being distributed directly to providers.
Mm-hmm. So a role you could play, though, is in putting the data together across the managed care providers to get a broader look at how the providers are performing. That's not just single payer, because maybe the Medicare managed care organization doesn't have a broad enough view about the provider. Like they might not have enough even statistical stability based on the number of patients that they have. So if it were possible for you to give these kind of data back to the Medicaid managed care organizations on the state more broadly, that might be helpful.
That would be helpful. Great point. Beth Bodan-Sauer had a very interesting set of comments on the procedures themselves. Beth, do you want to give a kind of a quick version of that?
Yeah, sure. Carrie, this is great work. It's fantastic. And it was just kind of in line with what we saw in our Quick Strike project on, the drivers of these things are very different. And so that means the fixes to these things are going to be really different. So I really appreciated your last couple slides there on looking at what might be driving some of these things. We have to be able to measure them for sure, but then also what do we do about that? Well, some of these could be, and I think Carlos mentioned this too, IT system setup fixes, it's incentives to the right people and making sure the lever that we're pulling in more than one direction is the right levers to be pulling. So I just appreciated that. And one really quick comment, we also did try looking at at a very high level qualitatively what these states looked like differently for our findings, and in terms of the low value care levels that we saw in different states, and we saw one of the things that jumped out at us was that those states that have access to a lot of medical services, so access kind of in a different way, but teaching hospitals and large systems and those that can refer do and those that can maybe do more in terms of these services, actually do more in those services. And so it was interesting. It lent itself well to Mark's conversation on the screen door. And he often will say we can't shut the door, but we can't open the door either, because when we do have access, we use it. So good work, Carrie. Thanks.
And thank you, Beth.
I also just noticed two of my colleagues, Wendy Yang and Maya, who I mentioned in the beginning, are on. And Wendy created the wonderful graphics you guys are noting. So thank you, guys.
Thank you. Ever so briefly, Lauren Vella, what did you see, Lauren, that surprised you about California? I don't know if you want to mention it quickly and take it offline later, but what was it, Lauren Vella?
Yeah, I mean, just because we have, a lot of delegated medical groups, and particularly, by the way, in Southern California. So, I mean, these are groups that conceptually practice managed care and take risk. We have more capitation in California than anywhere else. So you would expect that in California, these groups have the right incentives and infrastructure in place to not have so much low value care. So I don't know, I was just struck by.
Yeah, so keep in mind, this is Medicare fee for service, right? So all of Medicare Advantage and places where there's more Medicare Advantage penetration are not going to show up here. Like we're not showing Kaiser, for example, and don't just keep that in mind. I do think that providers don't necessarily differentiate. So if they have a large managed care population and they're being, their utilization is being heavily managed, I don't think they're saying, oh, this is a fee-for-service patient. This is but you can imagine that some of the different providers participate in the different programs.
Right.
I'm glad you noticed it though, Lauren, because California, as big and diverse as it is, whether it's the managed care side or the fee-for-service side, it still remains. There's a lot of opportunity here to do something about low-value care services. So thank you. In a moment, we're going, just a moment, but not yet. We're going to have our 15-minute break. Before that, I want to thank Dr. Carrie Cola very much for this presentation. Good gosh, Jack Wenberg would be proud. I will say that.
I haven't showed him the maps yet, but I agree he will.
You need to. Well, the maps, as soon as you showed the maps, a lot of us said, gosh, we've seen maps like that before from Dartmouth.
Yeah, even the title of my slides, ready to start with that.
He'll get a kick out of it if he hasn't already. Thank you very much. And really, your visuals are great. There's a lot of stuff. I think you're going to be getting some requests like, how can we use this? Can we borrow this? And so forth. There's a lot of utility there. So thank you so much. Also wanted to acknowledge we've had some folks join since the beginning. I'm not going to get all the names, but I did see Emily Ahrens, Munabanji, John Maffey, Troy Ross, and Hassan Azar. I know are among the folks that have joined since we got started. Welcome once again. When we come back from our 15-minute break, which we're going to take in a moment, we're going to hear member updates. Yes, we're going to hear member updates starting at 2:45 Eastern. We're going to hear from Beth Bortz out of Virginia, Karen Van Call from Florida Alliance, and Kathy McKeon and Brian Kean from Merck as well, and perhaps others if we have time. They're going to each do like 5-minute quick overviews of what they've done since last we've heard from them. So it is now exactly 2:30 Eastern. Let's take our 15-minute break to 2:45 p.m. Eastern when we'll return our member updates. Thank you all this morning. Karen Johnson, Carlos Arance, Carrie Cola for your splendid presentations. We got a lot of meat here. We got a lot of grist for our mills. See everybody in 15. All right, well, it's 45 minutes past the hour. This next session on member updates will go to about a quarter past the hour. And so we're going to hear presentations from Virginia, Florida, and from Merck. And if we have a minute or two, if anybody else has an important update to share, we will try to take that as well. Just before Beth gets started, I think one of the themes that continues to emerge here is that the folks, the organizations involved in this task force share and learn from each other. And we heard a lot about Milliman, for example. Milliman has helped provide data sources, and its calculator and so forth has been used by multiple users here. A lot of experience on best practices and graded case examples is being shared all the time. So there is sort of a collaborative effort going on here. And among our greater collaborators actually is Beth Bortz. So Beth, tell us what's up in Virginia, please.
Well, thank you so much, Cliff. It is a pleasure to be here. And this is one of my favorite days of the year. I love getting to hear what everybody else is doing. and try to pull pieces of it to incorporate back here in Virginia. So with just a few minutes today, I want to start and just first thank Arnold Ventures, because as so many of you have heard, they're supporting our work, as well as Milliman and our use of the MedInsight tool. And then, I would be remiss if I didn't take a minute and thank Kyle Russell and Virginia Health Information, because they're the ones who make the data happen. To start, I will tell you that, 3 to 5 minutes is not nearly enough for me to tell you what's happening in Virginia. So instead, what I've tried to cleverly do is entice you all to learn more by going to Spotify or Apple Play and listening to our new podcast, Smarter Care Connections. If you'll go to the next slide, I've listed for you, we have 8 podcast episodes out right now. You will see a lot of familiar names, a bunch of you that are on this call. We started big picture, and then the last 3 have actually been interviews with 3 of our 6 participating health systems. And those are really about what's happening on the ground at the system level. Next slide. So just as a refresh, the Virginia initiative, we are working to tackle 7 provider-driven measures of low-value care. We have 6 health systems, 3 clinically integrated networks, 1,000 practice sites, and 7,000 clinicians participating in our work. Before I go into the employer side, I just want to take another minute and thank those systems, because when we started this, no one knew that in the midst of their active intervention, literally, within weeks of it starting, they would be facing a pandemic. And so the really exciting thing I will share with you is that every single system, every single clinically integrated network has hung with us. They're still working on this. They have made it a priority. So, and as I joke, we'll probably have the best data ever, because we had periods where we had no elective procedures. But that, in seriousness, the evaluation will be a challenge, but our team is up for the challenge. One of our deliverables was to create an employer task force in Virginia. I mentioned a little bit earlier that we are concerned that, what happens if our clinician side does such a fabulous job that the only outcome they see is a loss of money in a mostly fee-for-service environment that is paying for these services. So we need to get our employers engaged. We actually asked our employers to help us with choosing a second set of measures for work. We wanted those to be more consumer driven. The ones we chose in the first batch were things that no patient really ever comes in and asks for. But we wanted the employers to help us with the ones where patients do ask for things. And so you'll see here, they have chosen their 6 from the Virginia data, and that will be hopefully our next phase of work. Next slide. The real secret sauce, I would say, in Virginia for our clinical teams is that every team gets once a quarter customized data reports to how they want them to look. And I just gave you a couple here just to kind of see. I know they're small, but really, Kyle and his team at VHI have worked, if they want them in Excel, if they want them in Tableau, if they want them integrated into their system-wide dashboards, Kyle does all of that. And they are able to every quarter see on all 7 measures how their system, how their individual practices, and how individual clinicians by MPI number are performing on the 7 measures. So that's really the heart of what we do. Next slide. And then I just wanted to close in my time today, and I think this is important, and it really reflects on some of the earlier conversations, that one of our 7 measures that was selected has to do with the reduction of PICC lines in chronic kidney disease for stage 3 to 5. And this was the one that was chosen really because of the harm factor. It's one that there's smaller numbers, but when it happens, it's very negatively impactful. One of our 6 systems, Ballot Health, chose this as the one they wanted to tackle first. They shared with us that part of the reason that they chose it was because while in the US, about 15% of adults have kidney disease, in Southwest Virginia, where they're located, that number is between 20 and 30%. So a higher prevalence. And that when a PICC line is used inappropriately, it can cause, there's a 57% chance of damage to the permanent damage to the vein. What this means for patients on dialysis is that once you don't have one of the 4 veins to go to, you have to go to a catheter in the neck. And as they have shared with me, that not only are the risks substantially higher to the patient, but the incremental costs are $30,000 every 90 days for that approach. So Ballad made this a priority, and I just want you to see what's possible when folks get involved. This is actually from their own EHR data, because as you know, claims data takes a little longer. So we're still waiting on the claims data to verify this. But what they shared to our employer task force just last week was that they've rolled it out at 4 other hospitals. They set a goal of a 25% reduction. All of their hospitals that are participating have already reduced their rates, and 3 of the 4 have already exceeded the goal of a 25% reduction. So just wanted to end on a really positive note that despite COVID and all the challenges, our providers are very committed to this work, and we're excited to move forward.
Beth, thank you very much. It's 2 things noteworthy, among others. The PICC line thing, it seems like the PICC line argument, a persuasive one there, apart from the costs, and that argument can be made, is the harms and the discomfort. This is not a pleasant thing to undergo, and there's a lot of downside to it. So depending upon the kind of the service itself, how the argument is framed can differ, but differ in a persuasive way. PICC lines is a great example of harms.
Cliff, that's a great point. I will share with you that when they do the presentation, the Ballad team, they actually start with, it's their patient story, and they call it, "This is our why." And they started by sharing one of their actual patients at Ballad, who was a 29-year-old female with type 1 diabetes, who, because of an unnecessary PICC line insertion and some, permanent scarring of the veins, now has a catheter in her neck and is at a very high risk. And she's 29-year-old single parent.
It's a patient-oriented story, sure enough. Thank you. And one other thing, I know, when I hear about secret sauce out of Virginia, I think barbecue, but your thing was custom reports. So I guess the custom reports, if they're your secret sauce, great. We always like to get our feedback and feedback about ourselves as well as how we look versus others. So no doubt there that's important, but it's another great example of, again, how you make the persuasive case. Thank you. Okay. Yes, wonderful. Thank you. Let's move on to Florida. Karen, you're up on the Florida Alliance.
All right. Well, thank you so much for including me today. And I want to say this has really been a particularly excellent meeting. I have taken so many notes and so much takeaway. So kudos to the team for putting it all together. So we only have a couple of minutes and I'm going to talk fast, but first I want to justify for why I'm calling the Employer Guide to High Value Telebehavioral Health a low value care service. We certainly intended to kick off our Smart Care Florida project back in January 2020 with the 5 priority areas from this task force and the D services that, from the USPSTF, but COVID got in the way. So what we did was take an area that was of utmost concern to the employers during the pandemic and teach them about how you can take a service and it could either be high value or low value. So I'll talk about that for a moment. And then we were able to carry out a non-essential drugs project and kick off a biosimilars project. And we've been working very hard behind the scenes to try to make it a priority for the state to see our APCD really be robust for research and for action. Next slide, please. So we are part of a national alliance effort called the Path Forward for Mental Health and Substance Use. And one of the pillars, if you will, is telebehavioral health. And the intent was to get 100% of health plans for the duration of this project to pick up telebehavioral health. And much like Beth jokes about how all the low value care went away, because of the pandemic. Well, guess what? Everybody, stood up a telebehavioral health service, but the vendors were coming out of the woodwork, and the employers were really just latching, many of them, onto something without really taking the time to look at whether what was being provided was high value care. So we pulled a task force together, and we really took the employers through what is evidence-based care, what data do you need to collect, what kind of answers should you be getting, what changes should you make in your benefit design to really ensure that telebehavioral health is integrated with primary care, both the data and the care. And it really has been very, very successful. Not only did we share it with our employers, it's been shared with the National Alliance, co-branded with them and sent out. So, if anyone wants more information about it, it was a really great opportunity to get the employers during this last year to think about how low value care is a complete waste. So I'll just kind of stop there on that one, and we'll go on to the next slide. So, we all lovingly call, Lauren, your project on non-essential drugs, your stupid drug list. We were able to work with one of our medium-sized employers over the last year to look at, and you can see on this slide, drugs that cost much more than others that are available, generic drugs that really aren't saving the plan money, and people were really surprised about that, new formulations of old meds that are driving up costs pretty frequently, and then scams that are happening behind the scenes, and people were all worked up over that, as you would imagine, but also to look at the uptake of biosimilars. And we are really, really diving in more about not just the biosimilar, but the reference product. Site of care seems to be a major driver. There are some patents that really are in place for the reference products that make the biosimilar more expensive, because you have to go, for example, to the doctor for the drug rather than having it dispensed perhaps through your arm. So really getting into the weeds on that. So this first employer that we did the initial analysis, and it didn't get into the biosimilar piece, but they identified immediate savings of over 400,000 on a plan drug spend of 2.8 million. And the key for us was to make sure that the employer had the tool to make the change. It wasn't just an analysis, and it wasn't just academic, and they are all in on diving in further on biologics and biosimilars. So that was exciting, and I hope other employers will jump on. The timing, obviously, this past year has been challenging for everybody. Next slide, please. And then regarding our all payer claims database in Florida, and Katie, I definitely want to connect with you on getting some of these states together, perhaps to do a demonstration project. Healthcare Cost Institute operates our APCD, and there's a website called Florida Health Price Finder that's up there basically for consumers to get up and see prices in a market. It's not perfect. It's certainly not, the best APCD in the state. I hope nobody's on who's going to tattle on me back to the state of Florida. But our concern mostly has been this really minimal self-funded data. The health plans have been really difficult to work with to get our employers to be able to provide, and their self-funded employers provide their data to the APCD. And one plan, who shall go nameless, who has been notorious for not allowing their clients to get their data not only in the all payer claims database, but onto RAND, has finally agreed to cooperate and allow, at least one of their major clients to do that. So that's kind of a big win. And we're going to, while that door's open, we're going to run right through it. We found confusion at the health plan level about whether the employers had to opt in or opt out. It is an opt-in for self-funded, and some are saying, hey, your data is going into this all payer claims database and we don't know what it's going to be used for. You need to opt out of it. So we've been working with the state to get very clear guidance from them that we can disseminate broadly. And as I mentioned, about RAND, there's that opportunity for the data to go on to RAND, but we're not quite ready for prime time yet, I think, in Florida for that. But an interesting change politically, Mary Mayhew was the Secretary of the Agency for Healthcare Administration in Florida until last October, and now she is the president of the Florida Hospital Association. So we've been having some really good conversations with her that I hope will allow the employers and the hospitals to come together in agreement about transparency in this space. So, really trying to catch up to a lot of the great work that, so many of the folks on this webinar today are doing. We're running as fast as we can. Thank you for the opportunity.
Karen, thank you very much. A couple quick things. In your non-essential drug list, the stupid drug list sounds like something that David Letterman would have had as an routine.
Lauren, are you still on your we've talked about that on this task force.
That might be hers. But quickly, just back briefly, Karen, to telebehavioral health. That's a pretty new area for a lot of us. And you said a lot of vendors are coming out of the woodwork. What do we need to watch out for or be aware of vis-a-vis telebehavioral health? Is there one thing or two that you might want to mention?
Oh, sure. So a lot of them are not using measurement-based care. And, that's pretty critical in order for the employers to be able to gauge whether, they're getting value, out of the cost, what are the outcomes? And, and providers in the mental health, behavioral health space haven't all used measurement-based care. And obviously in physical health, that's the norm. So that's certainly one. And when you have your telebehavioral health provider not connected to primary care, that disconnect can be deadly, in fact, for folks. So not only the data, but the providers being connected, we find that, if you have a serious physical condition and your depression, for example, is not being treated, you're not going to adhere perhaps to your medications or your treatment plan because you just can't. So making sure there's that connection. And that's behavioral health wasn't really thought of as, being critically important at the time.
Well, thanks for pointing that out. If vendors are coming out of the woodwork, but they can't provide warm handoffs to other clinicians as needed, that's a steep cliff from which to drop for some patients, I'm sure. Thank you very, very much. And then you mentioned biosimilars. I happen to know the Academy of Managed Care Pharmacy is doing a lot of work in biosimilars and the hurdles and barriers to getting those used as appropriate. So thank you. That was a great overview. Covered a lot of stuff there, Karen.
Okay.
Let's now go. Thank you. Let's go over to Kathy McKeon and Brian Kean at Merck for an update on some new developments there. I believe Kathy's going to start.
Yes, Cliff, thank you. And thank you for the opportunity to speak today. I really enjoyed the meeting. So what I'm going to advance to the next slide. What I'm going to try to do as succinctly as possible is kind of give you a broad overview of a very complex project. So we are currently embarking on a value-based insurance design in oncology. And I think all of you know, being very much part of the employer community, there's really a paucity of data of that type of model in oncology. But just to give everyone kind of some background, a couple of years ago, I had the opportunity to do a special assignment where I got to interview over 24 different CEOs, and waste and inefficiency was one of the biggest things they all talked to me about, right? In addition to their oncology spend and the trajectory of that spend. So I went back to Muna, just seeing this gap, Muna Banji, who's on the line, and I just chatted with her, and right away she got it. She's like, Kathy, let's do it. Let's do this project. So again, I'll try to be as succinct as possible. So phase one, we used the Milliman waste calculator. And what we did was we looked at 48 value care services, and the findings to phase one were not surprising. We found that 35% of our 72,000 members were exposed to at least one wasteful service, meaning that there was a real concentration of wasteful events that were taking place with specific members and providers. And of the $435 million that we spent on healthcare in 2019, about $10 million, $10.5 million in waste. So again, we wanted to take that financial headroom, right, and move it over to the oncology. And those inefficiencies were the usual suspects. They were, pre-ops, annual EKGs, lower back pain, waiting 6 weeks for imaging. So they were the usual. So the oncology piece to this, as everyone can probably appreciate, is really quite complex. So then we move into phase 2. So we broke this up to milestone 1 and milestone 2. The first milestone is one we looked at the highest incidence and prevalences of the cancers for our employees. Now, let me just take a step back and tell you, Merck tends to be an older company as far as mean age. We're not as young as, like, say, the Apples of the world. And so those cancers were far and away breast cancer, cervical, prostate, lung, and colon cancer. Now, we spend approximately $28 million a year on oncology, and 52% of our spend came from these top 5 cancers. So again, we didn't want to boil the ocean. This is a pilot. So we were very, very laser focused in on these particular cancers. And we looked at the following KPIs. So we looked at precision medicine, time to diagnosis and time to treatment. We looked at second opinions. And I just want to pause for a moment. 70% of people who are diagnosed with cancer in the United States, they don't seek out a second opinion. They're afraid, they're frightened, they're frozen, they trust their doctor. And I really did some digging with the research around this. And I found actually one extraordinary study by Mayo that people that came for a second opinion, 88% left with a refined diagnosis and 22% left with a diagnosis that was not cancer. So second opinions really can't be emphasized enough. The other part was screening and prevention. And so just to give all of you a tease, one of the data that we got back, and we're working with a partner called EXL, who's really helped us with this, is we really found something very interesting. A significant amount of these patients that did develop these 5 cancers, they went from being, costing us like $56 a month, like very low, to 86 times more. They went from low to high. Why? They didn't get their screenings. They probably didn't have primary care, physician, etc. So again, that was one of the big opportunities thus far we've seen from some of the preliminary data that we've done so far. The other thing we're looking at is sites of care. We know that sites of care, because of reverse incentives, etc., can vary by 50%. And then, of course, ER, rehospitalizations, etc. So that is where we are currently with this particular project. And then I just want to say a couple of words about scaling up and what we're going to do with all this. So again, we haven't gotten all the data. We're in the midst of this. Is that there's been tremendous interest from business coalitions around the country and from employers really wanting to understand how we do this and the framework from how we're doing it. So we are going to be writing up a paper. The one thing I did do very, very smartly was I made Mark Fendrick my advisor to hold my hand during this, particularly in phase 1. So we are going to be doing a paper, and again, there's a lot more work that needs to be done. This has been a very heavy lift. And I'm just going to pause for a moment because I am on with my co-leader, Brian Keehan, and Brian heads up U.S. benefits and wellness. And Brian has been an absolutely terrific partner. So Brian, I just wanted to pause for a moment and just see from your vantage point, since we've been doing this, anything that you'd like to share or anything that you think I've missed.
No, Kathy, I think you've covered it very well for us. What we struggle with, I would say, in our kind of work that we've started through with Kathy and her group is, the claims data only tells half the story, and that what we're trying to do is really tie that back to those claims data, right? The high cost that comes from that low risk group. What happens to outcomes when somebody does get the proper preventive care? They're in compliance with their screening. They're getting into the right centers of excellence and getting treatment in a timely fashion. So what we're really trying to understand is the difference in outcomes between that and somebody that does not do all of the prevention angles. And I think that's probably the bigger struggle that we have at the moment in this project, but I think it's something that is achievable. We just have to continue to press to get the innovation.
And thanks, Brian. And the thing I will tell all of you, one thing that's really neat about this is we are creating a dashboard in real time. And it really gives Brian and the HR team an understanding of depth, breadth of our own employees. And I think that's something that all employers, right? They want to better understand their own cohort so they can better design those. So this dashboard, we're really very excited about. And I think that's about it, Cliff. We tried to do this in 5 minutes, which was kind of tough, but I hope we did an okay job.
You did a great job, really. Thanks, Kathy and Brian. And I just want to take note that the idea of creating budget headroom feeds in nicely to the VBIDX concept, as you pointed out. The second opinions was an essential point that you raised, and we're really glad that you captured that. Brian, thanks for talking about the struggle. We get it. And then I noticed in the chat box that Muna, and it's always a good idea to go to Muna Banji for advice, as you did. Can't go wrong going to her. So thank you, Muna. But she did point out that, remember, it's not only the employees, but it's their dependents too.
Absolutely.
And so when you're kind of pitching this or framing this or messaging this, you got to think really broadly. And you've set a really fine example of doing that. So thank you very much. If anybody on the call has a 30-second to 1-minute update that they really, really want to share with people, just now speak up. I'm going to open the mics, as it were. Does anybody have a 30-second or 1-minute update they'd like to offer to the group?
It's Cheryl. I just wanted to mention that I am in agreement with the multiple comments today about us making huge strides by getting rid of unnecessary and wasteful practices since COVID, because obviously people weren't getting needed care either. And our members have stated loud and clear, we don't want to go back to the same way things were before. So we're going to look at those unnecessary and wasteful practices and treatments and even some elective surgeries and talk to our health plans about changes that we believe need to be made. So I just wanted to share that.
Well, thank you very much. And actually, you know, that kind of points up the greater sort of opportunity here for knocking down low value care. What's going on here? Healthcare systems are going to be under rougher budgets now. There's going to be a lot of backed up, pent up demand here. We've seen the disparities grow. It would seem a really good time to stop wasting money and increasing harms over benefits for some of these low value care services. So point very well taken, Cheryl. Any further comment? Does anybody have a 30-second or 1-minute speak out about their particular program? I'll give a couple seconds for that. And then if you don't, I have a final question for Beth Bortz. I meant to ask Beth, of your top 6 low value care services, 4 of them had to do with imaging, CT and MR. And I'm just wondering, are you getting any pushback or flack from the radiology community in the state?
Not yet. But that doesn't mean we won't. I mean, but employers did it based on looking at their data. So, you know, the data drives our work. But yes, we may hear something.
I was just thinking, if I were a radiologist and I was running a couple of imaging centers, if I started hearing about this, I might take notice. I'd say 4 out of 6, huh? You're picking on us. So I hope you don't have to worry about that, but thank you.
Thanks.
Okay. All right. Thank you for the updates from Virginia, Florida, Merck, and a nice addition from Cheryl. So we're in good shape there. We're now going to turn it over to Mike Chernow. And before I do, I'm going to say that having spoken with Mike several times the last couple of weeks, Mike is getting antsy. Mike is saying, listen, we've been doing this for a while. I know we've made progress. This is a highly collaborative effort. Good gosh, we've got Arnold kicking in and Milliman doing its thing and people sharing ideas and so forth. But I am now impatient and a little restless. And so with that, I'm going to turn it over to Mike Chernow for him to tell you why he is so. Mike.
To figure out why I'm restless, you probably would have to delve deep into my childhood, but we won't go there. But I'm really thrilled to be able to give this presentation, and particularly given what's gone on today, my personal view, I texted Mark earlier, this has been the best task force meeting yet. My mother-in-law used to say that every Christmas. Anyway, you'll see the sort of angst I have in general in this whole space, and hopefully I'll get some reactions. I'm a little nervous for how this is going to go, but let's see. So, oh, next slide. So we know that low value care is significant, and we understand its resistance to change. So let me just point out that, you know, if you listen to Karen and the Washington Health Alliance and Beth and what they're doing in Virginia and some of the others, you would be quite optimistic, and I am, and I think there is outstanding work being done. But understand, you are listening to the leaders and the best in this. If you look broadly across the country, you're much more likely to see how much low value care there is, and more broadly, that it's persistent 5 years in the Choosing Wisely campaign. So next slide. I think Carrie or someone put up this slide earlier. It may have been Carlos, I can't remember. But the point is, this is from work that a bunch of folks did. John Moffey was a lead author. And what you basically see is that over time, the change in wasteful care nationally has really been modest. If you look at the third set of columns, any wasteful services on the right, on the top, I mean, you'll see that there's really been a very marginal change. This obviously masks some places of great success. If you put this slide up compared with Karen's, for example, you'd see the differences. But I think nationally, we adopted Choosing Wisely with a model that had something to do with, we would let people know where the low value care is and it would melt away. And the one thing I take from Karen and Beth's and other presentations is it takes exceptional people working exceptionally hard, building big coalitions to actually get things to happen. Next slide. So I don't mean to be dismissive of the pockets of success or the people around there who have been successful, but I'm really, the title of this is what I would like to do. This is getting to Cliff's antsy point. Where's the energy, sort of the broader energy gonna come? So I have, you know, I'm not that good with presentations. So is it gonna come from big health systems? Is it gonna come from the medical community? Is it gonna come from insurers? Or is it gonna come from employers? And we've heard, my personal view is that it actually is going to start with employers pushing the rest. And I think that rings true given what I've heard today and the important role that employers play. And while there are really some organizations that are bringing them together and doing an outstanding job of it, and there's certainly some really cutting edge aggressive employers, I wouldn't say that's where most of the country is. Can we go to the next slide? So, this is the on the low value care task force work that we did several meetings ago. We drafted in our toolkit, of which there's many tools, this draft RFP language. And I like the RFP language. I don't know much about RFPs. There's people in the meeting much more knowledgeable than I about RFP. But I did go through 2 RFP processes, mostly as an observer, to be honest with you. So I'm in the 9th year of my 6-year term chairing the benefits committee at Harvard. We are advisory to the provost. And frankly, a lot of the energy comes from our benefit consultants and our HR folks. But nevertheless, we had the health waste calculator. We had put this in our RFP language. It turns out my thinking now about RFPs, and I wish I could see all of your faces, but my thinking now about RFPs is that there's sort of the hard numbers section and there's the soft answer section. And this language goes into the soft answer question where someone writes the wonderful things that are going on in the health plan to reduce low value care. So once I'm done talking, and hopefully that will be soon, you guys can chime in. I'll look on the chat to just say, no, you're just wrong. But at least that's my sense of where we are. So can we go to the next slide? The theme of this entire discussion, and I really only have, I think, one slide after this one. The theme of this entire discussion is how can we move the discussion of low value care in RFPs from the soft response section into the hard response section where there's some real money at stake. So, Carlos talked about non-payment in the Section 4105 stuff potentially. John Morgan raised earlier the possibility that Medicaid might put some money really on the line based on measured low value care. And what I'm really interested in is I'm going to throw out some bold, and I'm not even that committed to these ideas, some bold ideas of ways that money could potentially flow based on the amount of low value care. And I want to hear pushback, enthusiasm, barriers, tell me I'm crazy, which is always, by the way, some of the most useful feedback to know when you're going down a rabbit hole. But so the two main questions are, how can we make elimination of low value care a competitive advantage for a health plan? I know a lot of plans are doing it. A lot of the plans that have been invited are the leaders in doing it. I'm not convinced yet that most health plans in the country view elimination of low value care as a competitive advantage for them. And again, I think the reason is because most employers aren't watching it very closely in what they do. They're not contracting on it. Again, I could be wrong, so I will be simply watching the chat for people telling me I'm wrong. There are examples within health plans where if they have an alternative payment model, for example, an ACO, the elimination of low value care then aligns incentives. But it's not clear to me, big picture, why elimination of low value care is a competitive advantage for health plans. And then the more important question is how can employers incentivize the reduction in low value care amongst their plans? So I know there's a lot of work being done. Again, Karen, you kicked us off today talking about the work you're doing with employers to push the carriers and to push the providers to eliminate low value care. And I'd like to see how we could formalize that and expand it, bring it a little bit more to scale with all the efforts you're putting in place. So I'm going to throw out two ideas. Still watching the chat. I should be watching how many people are hanging up on me, but I don't know how to do that. So idea number one is lower payments to carriers based on the amount of low value care. So at risk of pissing folks off, you could, for example, pay 95% on the dollar for low value care claims. So we at Harvard, we're self-insured. We pay for all of our claims. We could imagine in the RFP negotiating with our carrier, we will pay you 98 cents on the dollar, 95 cents on the dollar for any claim that gets flagged as low value care in a particular way. We spend almost $300 million at Harvard. We have about, I know from the HealthWise calculator, we have 3 to 4% low value care. It doesn't take a lot of reduction of that low value care to make meaningful money to us. We could lower the administrative fees based on the low value care that we observe and we measure. I know that our carriers have given us guarantees about total spending, but they haven't actually given us guarantees on low value care. So it's true that we want spending to go down, but we actually want spending to go down for low value care. And there's not really a mechanism to tie those things together. We could envision a different model where we have a low value care guarantee of some amount or some penalty is paid by the carrier if the low value care amount goes above some threshold, if you're above some standard deviation or some national benchmarking. I don't really have a good answer. So I was really, really important with this, really curious about what people's reactions will be. So I'm gonna read through the comments.
Mike, this is Cliff. I'll tell you what, I'll watch the chat for you and you can kind of conjure answers if you don't mind. I just want to make sure people take a very careful look now at the discussion questions. Just please capture that. How can we make elimination of low value care a competitive advantage? So there's a thought on competitiveness. There's something about incentivizing. There are a couple of ideas about lowering payments and a couple of bullet points under how to lower payments and to what extent, and or shared savings. And Mike, Karen Johnson had a good comment about RFPs. Karen, do you want to say a little bit about how that works and whether it's an impediment or not?
Yeah, sure. So having spent a good chunk of my career doing RFPs on behalf of purchasers, I was just going to say that, Mike got it right in terms of there's the soft stuff and the hard stuff, and the soft stuff is hard to evaluate, and the hard stuff is really where it's at. I think, and I also agree. So on that point, yes, right on. But I think measurement is hard, and making that measurement relevant to purchasers is particularly hard given so many of the things that we've talked about today, which are the things that Mark talks about as the clinical nuances. It's good for some and not for others. And so I do think it's in the measurement and the communication around that where we're going to have to get really precise. This is where we need the scalpel to talk about it and get really clear about what's high and what's low value. Because purchasers are still very focused on, I want a good experience for my people in this plan. So if this involves taking things away that they think they want or need, whether they really do or not, that's the hurdle we face with purchasers.
So, right. So
Karen, thanks. Go ahead, Mike.
Yeah, I just want to push. I agree completely, Karen. If you notice, my question to you when you were speaking was all about measurement. So we have tools like the health waste calculator. They are, I think, in many ways state of the art. They are not perfect, but you could adjust the penalties for the imprecision. So, for example, if I knew the low value care was perfectly measured as low value care, I might say I'm not paying you a nickel for it. If I think there's some noise, I could pay you 95 cents on the dollar, 98 cents on the dollar, and I could titrate what it would be. But the point is, it is going to get, I will watch on the line, on the chat, it will get pushback from a lot of folks because it ratchets up the pressure. The whole point of this session is to figure out ways of ratcheting up the pressure. And when you ratchet up the pressure, people get upset. So measurement is absolutely a barrier, but it's one that you've taken head on.
And it's doable. It's doable.
Thanks, Karen. And just, Mike, you should know that Josh is saying he's agreeing on the measurement of low value care being crucial, especially if these services will have dollars attached to the employer TPA contract. Good point. Mike Madalena has a comment for you. Go ahead, Mike.
So, Mike, I think especially in the public sector and competitive RFP processes, a number of these approaches would work. I mean, I think you could specify the measurement period, to Karen's point about specifying the measurement, but these other items, basically you could instill, I think, some competition. Have administrators quote, say you're required to say what percentage of claims are you willing to, this 95%, quote a number, suggest or have them quote, some sort of what percent of their admin fees are willing to put at risk in terms of some sort of specified rate or specified effect on low value services. And then that all goes to evaluation of the RFP.
Yeah, so Michael, I agree with that completely. And just to be clear, that's exactly what we did in our RFP process. Is we asked the carriers to submit a rate of inflation increase in claims, if you will. We didn't tell them what that should be, but it was a quantifiable thing. If healthcare spending grows more than X, we will rebate you X, Y, or Z. You could do the same with low value care. If you had, again, you need a tool for measurement. I completely agree. But given a tool for measurement, I think the employers could do a much stronger job of building into the contract real dollars to make this work. But I understand there's going to be pushback, and I would love, I haven't gotten to my last point or my last slide. I will in a minute. But yes, I agree 100%. You could ask the competition in the RFP process, which share of how much, which discount will you give us on measured low value care? I can envision, Mike, you can tell me it's crazy, where employers get the health waste calculator, whatever tool they want, and they say, we're going to measure our claims with the health waste calculator. We will pay you not a discount off that measured amount. What discounts are you willing to give us? And then let people compete on it.
And I think that would work because you would the benchmark or the method is specified in the procurement. This is the method that will be used, so everyone's on the same playing field.
So Mike Madalena, you think that there's a route there? That's like a practical approach, do you think?
Absolutely.
Okay. Mike Cherno, since you mentioned pushback a few times, going back to Florida, Karen, you had a very interesting comment in the chat vis-a-vis the kind of pushback you get and why. Could you kind of highlight that, please?
Sure. Well, I mean, to Mike's point, they push back on everything for the most part. But what they were talking about was the mechanism for identifying whether, in that instant, the care that was given was in fact low value care. It's kind of like, every provider has the highest acuity patient. It's kind of every single instant of this low value care was justified. So trying to figure out that mechanism was the conversation that we had, because we really did want to get it in the RFPs and then provide what kind of response we, the employer should be looking for. So I'd love to work on this. I mean, we've certainly been, trying to sit down with them to make it happen. And what we find is if you just have one employer working with a health plan, they're not going to do that one off. So we've really got to get, everybody together with a particular plan who has these large self-funded employers asking for the same thing, because they say it's got to be a mechanism that's built, through the claims processing, procedure.
And I think it has to work with the benefit consultants who do the scoring, as Mike Madalena, who I've worked with, has suggested.
Right.
You.
But we've had to help some of the benefits consultants understand how you'd score them. A lot of them don't know. They're not working in this space. A lot of the big consulting firms for sure, but there are a lot of regional consultants who the employers work with who don't.
Yeah, no, well, I'm not so sure how well the big ones do. And remember, we work with Milliman. But yes, I very much appreciate that. My only point would be in the RFP process, I would be fine if one carrier said, we're not going to give you any discount off of the payment for low value care. And another one said, we'll give you a 5-cent discount. At least there, it gives a competitive advantage to the ones who are working on it. And the ones that can do it best get at least a little bit of an advantage in the RFP process. Right now, at least in my experience, because it's so hard to evaluate the soft answers, low value care didn't make a bit of difference in the RFP process.
Well, and I think we came at them, Mike, with we're just not going to pay for the low value claim. We didn't say 95, cents on the dollar. So, maybe we shut the door ourselves by coming out that strong.
And just I know you're going to go on, but let me just say one last thing to Karen. Sure. If my measurement was perfect, I would have gone to 0. But because the measurement's imperfect, I use a much less.
Right. No, I agree. Thank you.
So Mike Chernow, that's how you're bridging the questions about credibility with regard to a claim being truly low value care or not, instead of taking Karen's original hard line of saying we're not going to pay, you're saying, hey, we'll pay 95%, and we'll try to save 5% there. We know that we know we can't prove that every instance was low value care.
And I'm actually, Cliff, where Mike Madalena was. I think he was very truthful, which is I'm not going to pick the 95%. I just want the RFP response to force people to give me a number. If they don't think they can do it because they can't control their providers or they can't deal with Jeff said something about that adequacy. I agree with Jeff's comments completely. But my point would be fine. Then say you're not going to give any discount. I don't want, I'm a competitive guy. So I'm like, okay, don't give a discount. But if someone else can manage their providers better and deal with the issues better, they at least should get some credit for that. The first point is, how do we make plans compete on this, not what we actually force them to do?
So Mike, say a little bit more. Given what you just heard in feedback, can we make the plans truly compete on this? What do you think now?
Yeah, I don't know. I heard Mike Madalena, who works with a lot of state governments, and based on the comments that John Morgan made about Medicaid, I would like to think the answer is yes. I could envision a world in which it's not true. You need some employers. Cheryl's on the, Cheryl Larson's here. She might say something from part of a coalition. You may need a coalition of folks to get this into the contracts. I'm not sure. And it does, I probably should have led, this just shows you I'm an economist. I probably should have led with the carrot, not with the stick. So there's another version of this, which is my last bullet point here is don't penalize them, but just share some of the savings from reduced low value care. Measure their low value care at benchmark the way that Karen did in Washington Health Alliance, and share some of the savings if the carriers can reduce that to a lower number. I am an economist. I tend to be a stick guy. I'm a nice enough person, so I'm willing to be a carrot person if that's what it takes. But I'm not sure. Either way, it forces people to do the math.
Okay, so I've got 3 people in the queue trying to get this in a rational order here. Cheryl Larson needs to make a point about the employers. Chris Jude has a point to make about collaboration, and Claire Levitt has a comment to make about the plans that are self-insured and who's responsible for what. Cheryl Larson, please go first.
I'm not sure what you want me to say, but I did have the idea that I'm doing later this month an employer advisory board with several coalitions, Karen's coalition, and a few others on how we're going to pay for high cost therapies, and waste is one of the subtopics. So if you guys had 3 or 4 questions you wanted me to ask these employers, I would be happy to do that. The challenge, of course, they're going to face is, getting the plans to be willing to do anything, because the plans are always worried about taking money away from the docs, and, they benefit from the overuse. But if there are some things that you'd like us to ask our members about, we would be happy to do that as part of this and some of our other initiatives.
Sure, we can do that. I might ask Mike to pose those to you, but before that, where we are now, given the way Mike is setting this up, how do you make the leap? How do you make the discontinuous change now in the current environment? Do any of the things that Mike put up there on the board look doable from your standpoint at Midwest?
I think you've got to focus on narrowing it and taking the learnings from what we've heard from our other 2 sister coalitions that were on the call today, actually 3, in terms of what do you want to focus on? Is it the top 5? Is it something beyond that? Before you can even talk about lowering payments, unless you have legislation in place, most markets, I don't see the plans doing that. And unless you can get them to agree to a contract that looks at these key elements, the average employer, that mid-size employer, and for us a mid-size employer is 500 to 5,000. It may be different for every single coalition around this world, or this country, I should say. But I think that you've got to get them to buy in, as we heard from some of our other colleagues, on things that they obviously know are wasteful, and focus on those things too. So it may wind up being a tiered approach.
Okay, good. Thank you. Chris Jude, you had a good comment to make. Please go ahead.
Yes, and this
Summary
is
of what
probably
you have in
going.
the chat.
That's okay. It's probably going to look more on the supply side, but this is talking about maybe some more of a national quality strategy, if you will, to align the incentives so that the plan is getting some type of benefit from, like, either a star rating or, some type of other, quantitative measurement. And then the providers can do an improvement activity in MIPS that they're addressing low value care, or they're implementing choosing wisely, or, depending on their specialty, and that can be documented. And then they're getting some kind of benefit on the backside, if you will, through their performance incentive program. And it's not just a pure loss of revenue because of stopping services or cutting down on unnecessary services. And that could also help with, I know Muna had in the chat regarding how do you account for clinical nuance. Part of that measure could be at the clinician level, that you evaluated the patient and determined that, based on low value care, this person did justify that, that there could be some attestation or something.
Got it. Thank you. Claire Levitt is going to tell you, Mike, who should get paid less. Claire, what do you got?
Well, my concern about this is the focus on the carriers as opposed to the providers. The carriers, in many cases, especially with the self-insured employers, the carriers are doing whatever the employers tell them to do. If the employer doesn't say don't pay for low value care or pay less for low value care, then the carriers don't have any ability to deal with it with their providers. I'd like to see not 95% on the dollar, but much less than that for low value claims, or also see employers saying that we're just not paying for low value claims. I also think the concept that came up about incentives is important also. Providers need to have some incentive. Maybe they need to get more for their high value claims and less for their low value claims, so that they're not just taking a hit financially. But I think until employers are willing to embrace this, that the carriers are not going to embrace it.
So Claire, how then might you advise Mike and all of us about the points you see in the discussion slide? Would you be in a position to vouch for one or more of those, having heard what you've heard and the comment you just made?
Yeah, I don't, this is very difficult, and we have had difficulty with it in the city of New York. It's hard for us to get our unions to go along with it. It's very difficult, but I do think that if we don't create the proper incentives for the providers, that it's much more difficult to get the carriers to go along.
So can I just jump in 1 second?
Please. Absolutely. Go ahead, Mike, please.
So I absolutely agree. Most employers, particularly the mid-tier employers you were talking about earlier, don't actually engage the providers. They have to pressure the carriers to engage the providers. I happen to know we have Carol Huffman and maybe some other people now from Emblem on the line. They are actually one of the leaders in low value care elimination in a whole bunch of ways. Carol can speak to what they're doing, but they're doing wonderful things at Emblem, and they actually own a provider group that they can manage in a whole variety of ways. I realize the complications, but my argument, and Carol, you should jump in because I don't really know much about this, is I am not convinced, and I could be wrong, that they're getting the competitive advantage they should for the efforts they're doing to get rid of low value care because of the extent to which employers are more aggressive in rewarding them. In fact, the theme of this entire talk is how do we energize employers to hold the carriers accountable for holding the providers accountable. That shows you what's wrong with American healthcare, for holding the providers accountable for the low value care they're delivering. And I would love, obviously you are an employer in this context. The bolder you are, the more you can reward the carriers that are doing the best job if the right measurement tools are in place.
Mike, were you asking for Carol Huffman to comment? Whom were you asking?
I was talking for Carol Huffman to comment, but I think Claire's going to respond and tell me what I got
please,
wrong.
Claire. Go ahead, Claire.
Well, I just want to respond that Emblem Health is our largest carrier in New York City, and we've encouraged them to go after the low value care, and that's part of the reason that it works.
Exactly. So this terrific. I can do my little thumbs up reaction.
Okay. All right. Did Carol Huffman want to comment as well? I'm not sure if she was there. Okay. So further comments. This is one at the nub of this now, and Mike set it up and Claire helped respond. Mike is basically saying, how the heck do you make employers more aggressive and take a more aggressive RFP stance? As we said earlier on this afternoon, there's a broad range of employer willingness to really sort of lean right into this and be more aggressive and take a stronger stand. What do we need to suggest to Mike, or how can we react to Mike about what that would take? And anybody can kind of chime in verbally if they want. Don't have to put something in the chat if you got a good answer. How do we get the employers to take a stronger stand?
Hey Cliff, this is Mark. I've been quiet for 3.5 hours. Can I call a couple people?
If you sure, go ahead, Mark.
I'd love. So Carol Mendoza has been in these roles. She's now a free agent, so she might be able to speak a little bit more freely. And Jason Parrott, I believe you're on. We're thrilled to have you. I know you've thought about these issues for maybe even longer than Mike and I have. So,
Carol, what do you have? Carol, then Jason.
Hi there. I think employers would be very interested and just haven't thought about this, but would like a framework. Like, what do I take to my carrier to ask for this? How do I start?
So how specific would you have Mike Chernu be?
Well, I think what he showed on his slide was a good start. Yeah, I mean, I think that's the right place to start.
I think part of the issue is working with the EBCs. What I've learned is they're the ones that manage this. So I don't know if Robin Kahn is on, for example, but getting the EBCs to work with the employers as they're building out their RFPs seems to me the first place to get the language, to move the language. Again, the theme of this is moving the language from the soft to the hard part of the RFP. I'm not sure exactly how to do that. I'm pretty sure the entity that will do that is going to be the EBCs, and they will only do it if the employers push the EBCs to do that. Then the people respond with whatever they need to do.
Yep, I agree with that.
Excellent. Robin Kahn and/or Jason Parrott, reactions.
Jason, you want to go first?
Thought I saw Jason. All right, Robin, why don't you go ahead?
Yeah, I mean, I think it's, the points are valid that the benefits consultants are involved in the RFPs. I think there's a lot of times where we will bring ideas to the clients or the clients will bring the ideas to us. So I think it's, whoever wants to start the conversation, start the conversation.
But what will prompt who will kickstart the conversation? How will that happen?
I think it's getting the word out there on the value of doing this and proving it out, right? So how are we getting the message out that says all of this is considered wasteful? And how are we going to make sure that the carriers can then come back and prove, right? To the points that have been made on this clinical nuance, and if it's requiring the carriers to put more pressure, it's a downstream impact, right? So if the employer holds the carrier accountable, the carrier has to hold the provider accountable. But what does the provider do when the patient comes in and says, but wait, I heard I need a vitamin D test, so I understand whether I'm at higher or lower risk for COVID. Are they going to say no?
And I agree completely with that. I agree 100% that is the dynamic here. While we continue this discussion, Cliff, can you just go to the next slide, which will make my last point?
Yeah, next slide.
Yeah.
Basketball.
Well, yeah, I'm going to describe who it is. I'm going to talk through it. The key point is, I think we need a champion in order to get some success stories so we can come back and have someone say, we put this into our RFP. So I know, I think Hassan, he was on the line. I'm not sure if Hassan's on the line. I don't know whether. Hi, Hassan.
Hassan is on the line.
I am. How are you?
So I don't know what stomach employers have to begin to move the low value care portion of the RFP. I'm not even sure, Hassan, you have a low value care portion of your RFP, but I'm not sure what it would take to get you to move that portion of the RFP from the soft to the hard part of it. The measurement part, I think, could be easily done because I know almost everyone here uses the health weight calculator. I love the health weight calculator. It doesn't have to be that, but at least that is a feasible thing that people could do. I'm sure the Milliman folks would love to work with the Towers Watson people or with Mike Madalena or with whomever employer to help them build that if they wanted to do that. I'm not worried as much about the measurement. I'm worried about the will of the employers to do it. So Hassan, maybe you have some thoughts.
Hassan, remind people of your affiliation, Hassan.
Hi, I'm the head of benefits for Jones Lang LaSalle, the global real estate company.
Thank you.
And I've worked at a number of organizations. This takes me back to 15 years ago when I was running healthcare programs at Ford Motor Company, and we were early on and demanding NCQA accreditation. It's funny, I was talking to the NCQA the other day, and it's disappeared from all of our RFPs because no one's paid attention to it. But and a lot of companies are taking an interest in cost and quality like this, but a lot of them don't know what to do. And I think, Mike, one of the issues is if I have 3 or 4 things on fire right now, is this one of them? I don't do an RFP every year or even every other year of our health plan. So I think there are some coalitions on the phone right now. I think this is something that a number of employers have to do together, because if 1 or 2 of us are just tackling it, it's not going to get attention fast enough. So I think, Cheryl, and you, I'm on your board of your coalition. I think it's going to take a lot of actors to pay attention to this.
Hassan, but what's your hammer? What makes it happen, Hassan?
What makes me go out and do this?
And the people about whom you were just speaking. How do they get over?
Yeah, and you won't want to hear this, but right now, when a lot of companies, their healthcare costs dipped below a normal trend last year, our burning platform got a little softer. A couple of years from now, when that gets a little out of control again, then we will start going after things. But some of it depends on how bad things are on fire at our company, to be honest.
So we got to look for your company to be on fire. Gwen Darian, thank you. You're up next. Gwen, you've been waiting for a point.
Yeah, thanks, Cliff. So, I mean, we've gotten very far down a path that was that I actually was hoping to interject in a little bit earlier, because I think we're getting very far away from the people, we're considering we're not considering people as the center of this and healthcare as the center of this. And so when I asked who defines what is a good experience and how does that align with patients and families and community values, Karen Johnson replied to me, it's in her experience that it was purchasers, a good experience was that measured by lack of dissatisfaction. So rather than being so, I would actually try to put this in a much more positive perspective, which is that this is employers employ people. And if we're talking about what gives a competitive advantage, it's an advantage of a healthcare, it's an advantage of a plan that has the best outcomes for patients that align with what they want and what they need and their goals and values are. So I just wanted to inject a little bit more. I wanted to inject a little bit of that perspective into it, and also the perspective that this is these kinds of things are what really drive good care and good outcomes, and that's what we're ultimately looking for.
Gwen, do you have to put this into RFP language? How do you make sure Mike's wanting to bring down the hammer? Well, the hammer could look like a carrot and or stick, but what's the reminder? What do we have to put in there as a conditional for this to protect the people of whom you just spoke?
I actually think you have to move back a step or two and help as these RFPs or as things are being crafted to find out what in somebody's mind would be a good health plan that would give that organization and that employer competitive advantage in the way that they're taking care of their employees.
Aha. Okay. Mike, let's go back to the previous slide for Mike's points. Okay, and Mike, are you still in search of a champion or a set of champions for any one or both of your two main ideas or other? What do you really need, Mike?
So I am absolutely looking for a set of champions. If we could be all together in person, which I would like, I would, buttonhole you all over the pistachios and M&Ms. You could be at the pistachios. I'd be eating the M&Ms. See. I don't think we need to get everybody. I think there's going to be a different taste by different organizations, different insurers to do this, to find if there is a carrier, public or private, that is willing, not a carrier, an employer or a purchaser, public or private, that's willing to work on RFP language that is bolder, if you will. And what I would argue is the hammer we have it could be a tack hammer or something much smaller. I'm actually not arguing don't pay for low value care. I'm not even arguing don't pay for vitamin D testing, much to Mark's chagrin. I'm just arguing pay less for it or hold someone accountable financially in some other way that you measure it and you adjust it. So this is my core concern is unless you have really, really, really exceptional people putting in really, really, really exceptional work. And although I haven't worked as much with Karen in Washington, I have done with Beth in Virginia. And I know the lift that's involved to get the success that they have had. And it's hard, I think, to scale that. I think if we had a broader movement where money was moving the way we've done things around other types of cost-saving approaches, there might be more movement around low-value care. So I think I have gotten to say my piece, and I am unbelievably grateful for people's willingness to listen to it. Now that you know where to reach me, Mark, or anyone within earshot of me should reach out. And I would love to see where there is movement for champions to set the bar. I know there's a lot of things. There's Boeing, Walmart. There's folks from both of those employers here. They're known as innovative employers in a whole bunch of ways. When they've done things, centers of excellence type programs, or when Boeing did some of its payment models that we've heard about in the past here, these were really innovative type activities. And I think pushing on low value care would fit into that portfolio.
Okay, but Mike, allow me to ask you to be a little bit more specific. Are you saying that you want to take that RFP language, the 3 lines of RFP language you showed on one of your earlier slides, and what you want is a small group of champions, at least half of whom are employers, to work with you to amend that RFP language.
Yes.
Is that
yes?
okay?
And to get it in, yes, and to get it inserted in another part of the RFP. I think John Morgan calls it the scorable part.
Okay, so that's basically, sorry for the cliche, that's the ask. That's what Chernu's putting on the table, and I don't know that we can take volunteers now, but I'd be glad to take them. But I'm just kind of scanning down our list here. I see people with combinations of their employers, large employers and mid-sized employers. I also see people whom we know, have already kind of stuck their necks out and made big changes in their states or in their provider communities. And so there are potential champions here aplenty, Mike. I'm thinking about, I can see 8 or 10 people that come to mind who would be good candidates for this, but that is the particular ask. And Mike, one more thing. Would this revised RFP language lean to one or more of the lower payments thing or the shared savings thing?
That's up to the people who are doing this. That I don't have a really good answer to that question. I would take either. I would give people a choice. I would just like to get it to a different part of the RFP.
Got it. And I note that one Beth Bort says, I'm volunteering already. Good gosh, Beth. Once again, you are, what do they say, the tip of the spear. Thank you. So we've got one volunteer already, and we're going to look for other folks to contact Mike. Maybe what we'll do is after this convening of the task force, the staff will send out a reminder email to folks along with whatever summary information we're going to share, with a reminder that we're seeking champions to work with Mike on revised RFP language, and being bold is a criterion for membership.
Yeah, I saw a few in the chat, some private to me. I'm not sure I've caught all of them because I'm not so good at following as it flips by. But anyway, thank you, Cliff. I think I need to get to the slides after my presentation so I can thank all of the relevant.
Over to you, Mike Chernu, for closing wonderful remarks. Mike?
Yeah, so, now I get to really be thankful, not just for me, for people listening to this. Next slide. I really, really, really want to thank our sponsors who have been unbelievably generous and helpful in pushing this agenda forward, given what we're doing. So that's thanks to AbbVie, GSK, Johnson & Johnson, Merck, and Pharma. We really, really appreciate your help and your engagement in this and the related conversations we've had. So on behalf of Mark and I think really on behalf of the entire Low Value Care Task Force, a really sincere thank you. Next slide. So I need to thank the staff, Susan Lynn, who is really high value service beyond what all of you may know, Jordan, the entire team that helps put this together are really exceptional. And for those of you that know Mark and I, they get really extra credit for that. And I want to thank all of the speakers. I'm not sure how many are on now, but all of you are really exceptional. I was sincere when I said, at least prior to me talking, this was the best task force meeting I can recall, although I think it's better in person, but nevertheless, I think the substance was really outstanding. So I want to thank all our speakers. And again, I want to thank all of the folks that have been engaged in this. It is hard to be engaged in a long Zoom, and I really appreciate the engagement, even at the end, at my part. I think it really speaks to both the importance of the issue and the caliber of the people that have been involved. So thank you all. We will be holding another virtual Low Value Care Task Force meeting. Hopefully we'll have more to report on October 14th, again, 12 to 4. So that's going to be my big thanks. And I don't know, Cliff, if you want to leave with anything else, or if Mark wants to say anything, but I think we are wrapping it up, and I, again, am incredibly appreciative.
Mike, thank you. I just wanted to note that you've got several more volunteers and some great comments. So we're not going to lose what's in the chat. We need to hold on to that. So let's preserve that for volunteers and some final great comments. Back over to Mark Fendrick, since he was a request.
No, because I told Mike to not call on me, but he did. Thank you, everyone. This has just been remarkable. 9 convenings. I know we say this every time, but everyone gets better. Every one of these meetings is better and better. please put October 14th on your calendars. It will be virtual. I am extremely hopeful that at roughly a year from now, we will be able to meet in person so we can watch Mike eat M&Ms and the rest of us eat Susan Lynn's amazing snacks. So thank you all. Cliff, as always, absolutely superb. And we'll see everyone in October virtually and hope to be in touch with several of you in the meantime.
Great.
Thanks, everybody.
Yeah.
See you October 14th, if not before. Great meeting. Bye-bye.